Well, good morning. I'd like to call the meeting to order. Secretary Johnson will be joining us shortly, and in the meantime, we will do roll call.
Good morning, David Dr. Carlisle.
Present.
Dr. Sandra Hernandez.
Here.
Secretary Kim Johnson. Richard Kronick.
Here.
Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Dr. Richard Pan.
Present.
Don Molds.
Here.
We have 7 present, 1 absent.
Great. With that, we will establish quorum. And now I'd like to turn it over to Director Landsberg.
Thank you, Madam Vice Chair. Good morning, everyone. I'm just going to start by going over our agenda. And we have 5 very substantive informational items. So first, we'll be talking about the office's recommendation for hospital sector target methodology and values. Along with the slides for this meeting, the office posted our memorandum required under the statute anytime we are proposing a target, which commences a 45-day comment period, and the team will be talking more about that process when we go over the proposed methodology and values. We'll then be talking about the proposed hospital sector definition regulations with the board's unanimous vote at the last meeting to establish hospitals as a sector. Our next step is to promulgate regulations, and we'll go over with the board and the public those proposed regulation, the draft of those proposed regulations. We then have a preview for you of the baseline report, which is due this June, and we'll go over some of the content. We'll talk about the THCE proposed regulations, and then last but very much not least, we'll be having a conversation about the behavioral health investment benchmark, and look forward to that follow-up conversation with you all. So now I'll go ahead and just move to my executive updates. And I'd like to start by recognizing that this month is Black History Month, and we have posted on our slides HCI's Black Liberation Statement, which was developed by our racial equity team. So I encourage you to read it. I won't read it to you, but do want to note that working for health equity is at the core of HCI's mission. And we believe a foundational step in furthering equity is to acknowledge our long history of intentional inequities, to name the violence and racism that has been perpetuated on Blacks and African Americans that underlies the health disparities that persist to this day. We also think it important to celebrate Black culture and the incredible resilience of Black communities. We are committed to furthering diversity, equity, and inclusion here at HCI and in the state of California. Next, I'd like to bring to your attention, it being February, the bill introduction deadline was last week to introduce bills in the California legislature, and would like to bring to your attention a bill that pertains to OCA, Assembly Bill 1415, by Assemblymember Mia Bonta, the chair of the Assembly Health Committee, would make some changes to OCA's existing law. So it would bring in 2 new entities defined as healthcare entities, both management services organizations or MSOs, and also health systems. So we've heard from you all, over our meetings of the last 2 years about the importance of collecting data by health system, not just by individual healthcare entities. And so if this bill were to become law, it would change that so that health systems would be considered health entities subject to data requirements and cost targets set by the board. In addition, there's a piece around cost and market impact reviews and private equity. So as you know, today healthcare entities have to provide OCA with a prior written notice of proposed transactions of specified actions, including selling or transferring their assets to one or more healthcare entities. And AB 1415 would similarly require private equity groups, hedge funds, or newly created businesses created specifically for the purpose of entering into agreements or transactions with a healthcare entity, those entities would also have to file a notice before a proposed transaction with a healthcare entity. So again, that would impose the material notice on hedge funds, private equity, and entities created for the purpose of those transactions. Okay, those are most of my program updates. I do want to remind the board, staff, and speakers to speak into your microphones. I'm trying to model that. And so I was watching you all during the roll call. Most of you did a pretty good job, but just be sure to make sure your mic is green and that you're speaking into the microphone, because this is a public meeting, as you know, and we do want to make sure that folks both in the room and online can hear all of your remarks. So those are my executive updates this morning, and I'll turn it over to Deputy Director Pagani.
Thank you, Director Lansford. I'll start with a brief summary of the Milbank Memorial Fund's February 2025 report on some key lessons learned from multiple state efforts to slow and shift total healthcare spending. The report describes the experiences of states that have designed and implemented policies to pursue multiple targets or benchmarks. For example, a statewide cost target or benchmark, a primary care investment target, and or the adoption of alternative payment models or value-based payments. The report gathers lessons from the experience of these states to inform future policy development. Three major themes emerged from the report. The first one is multi-stakeholder alignment requires a clear, shared vision and close collaboration. One way to achieve this is by creating a vehicle for public purchaser collaboration to drive engagement of other payers and stakeholders. The second theme was a shared vision is needed to articulate goals holistically, and that regulations can make the goal explicit and establish expectations. The third was enforcement approaches blend creativity, fortitude, and patience to achieve accountability. Effective examples include an expansive data collection and monitoring approach and fostering accountability through contracting language and regulation. With regard to these themes, I'll take a moment to highlight how it's worked in California. For purchaser collaboration, OCA has bi-monthly work group meetings with our state sibling departments that include the Department of Healthcare Services, CalPERS, Covered California, and Department of Managed Healthcare. In these meetings, we focus on OCA's proposed definitions for APMs, primary care, and behavioral health. We also align on data collection structures and processes to limit reporting burden on data submitters. This collaboration demonstrates how public purchasers responsible for half the state's coverage are actively engaged in the process and reinforce OCA's efforts in their contracts with payers. The next slide depicts how different states are currently addressing the task of slowing growth in healthcare spending. Connecticut and Maryland have set both cost growth and primary care spending targets. California joins Delaware, Oregon, and Rhode Island in addressing all three areas of healthcare spending described in the table. And then next, I'd like to highlight an article published this month on JAMA Health Forum, which examined 4 key drivers of per capita healthcare spending across counties in the United States. The key spending drivers that the researchers examined were age, disease prevalence, service utilization, and service price and intensity. For the latter 2 spending drivers, service utilization was measured as service volume per prevalent case, while service price and intensity was measured as spending per visit, admission, or prescription. The study found that service utilization explained a majority of the variation in spending per capita across counties, followed by service price and intensity, which explained about a fifth of the variation. The researchers also found that increases in median income were associated with more utilization. They also found that the share of physicians who specialize in primary care was associated with lower prices and intensity of care. while Medicare Advantage was associated with higher prices and intensity of care. For private insurance, more variation in spending was attributed to service price and intensity compared to other payers. In the next slide, we show figure 2 from the article, which shows factors that explain the cross-county variation in spending per capita. They have 3 graphs in the article. I'll focus on graph A. While service utilization and service price and intensity were clearly the largest factors, there were variations across each graph and factor. For example, in graph A, for private and out-of-pocket payer spending, more variation in spending can be attributed to service price and intensity than other types of payers. The authors note that the study provides signals for where cost containment strategies might be viable. They also noted that future research could focus on whether there are optimal rates of utilization and price and intensity of care that provides better outcomes. And then now I'll shift to discussing our slide formatting. As we do at every meeting, the yellow arrow indicates items for which the board, informational items for the board and decision items for OCA, while the green are areas that are within the decision making of the board. So that concludes my executive updates, and I'll return it back over to Chair Hernandez.
Thank you for those updates. Any comments or questions from the board? Richard Pan.
Thank you for those presentations. Director Landsberg, you mentioned a bill by some member, Banta. Do you know who the sponsor of the bill is?
I don't believe it's currently sponsored.
Oh, okay. All right. So I didn't know whether it came from the administration or it came from another entity or whatever. But okay. So
It's
there's
not currently
sponsored.
sponsored.
Okay.
That may change. Yeah.
All right. Okay. And then Dr. Yanni, so appreciate the presentation of the of some of the new data or information. Just out of curiosity, in terms of, for example, they said Medicare Advantage had lower utilization but higher intensity or cost. Now, I haven't had a chance to read the paper, but in some senses, if you were actually trying, well, let's say if you tried to reduce, let's say, utilization, I guess if you're trying to cut off the tail, wouldn't the average of the intensity and the services actually go up? Right. So if you're, I guess if you're putting more barriers or restrictions to people getting care, what would you expect to see? So people might try harder if they were sicker, and therefore, or they wait until they got sicker. Again, I don't know if that's what's really going on, but I'm just curious about that sort of that pattern that was described in the paper.
Yeah, they did talk about Medicare Advantage lowering utilization, and they did talk about differences in the types of services that Medicare Advantage enrollees use. I believe they used more ambulatory services, but they did talk about those dynamics.
I mean, I noted that finding as well. It's really interesting. I assume this is one of these associative or correlative analyses that doesn't imply causality. Right. Yeah. So this might have something to do with the population enrolling in Medicare Advantage as well.
Or the places in the country that Medicare Advantage has got higher penetration. Yeah, it's a cross-sectional study. Quite interesting, and I think useful in probably 30 years ago when Jack Wenberg was doing work at Dartmouth, there was a lot of emphasis on, variation is all about variation in utilization. And then Uwe Reinhardt and Jerry Anderson at Hopkins, ushered in a couple decades of, well, we need to be paying attention to prices. And, I think this paper is useful in pushing some of the attention back to, well, prices are very important, but utilization is important too. And in that way, it's kind of a useful study.
Other questions or comments from the board? If not, we'll take public comment on the presentations.
We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in the room may line up at the podium. Those attending virtually may click the raise hand button. If you're dialing in, you can press *5. It will track the order in which the hands are raised. During public comment, you will be unmuted when it is your turn. We also invite you to provide written public comment at the email on today's agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda today, except to place the matter on a future meeting agenda. I will look to the room and start with the individual at the podium. Please go ahead.
Beth Capel on behalf of Health Access California today. Just a few points on this first item. And as always, we learn from the board discussion. We were struck also by the variation in spending for private insurance. Medicare and Medi-Cal have rate mechanisms for both fee-for-service and managed care. We are, all of us, here today because private health insurance costs are too high. No, I'm talking there about the coverage sold to individual consumers and employers for their workers. This is why we are trying to control those costs. When we hear some say that there's a need to cost shift to commercial payers, what we hear is an attempt to increase the very high costs already paid by purchasers like individual consumers and employers. And we know very well that the providers who do the most Medi-Cal actually get paid the least generally on the commercial side. We also note, and in looking at the letters that you have received, that since the ACA, both state and federal law have required medical loss ratios and rate review for health plans and insurers. And now health plans and insurers are subject to the OCA targets. We note this because 80 or 90% of the premium dollar is spent on hospitals, professional services, and prescription drugs. That's where the money is, and that's what we need to look at as we're thinking about today's discussion. Thank you.
Thank you. Looking online, Monica, we see your hand raised. You should be unmuted on our end. Go ahead. Monica, we can't hear you on this end. You might need to unmute on yours.
Sorry, is that better?
Yes, we can hear you now. Go ahead.
Okay, thank you, and good morning once again. Thank you for the opportunity to speak today. For more than 100 years, Scripps Health has been a cornerstone of San Diego's healthcare, treating over 600,000 patients annually with the help of 3,000 affiliated physicians and more than 17,500 employees across our various facilities. And today I want to highlight the unintended consequences of the policies set by the Office of Healthcare Affordability. While we share the goal of reducing healthcare costs, the current targets are not achieving this. Instead, they are impacting access to care. These policies don't address the costs healthcare providers incur, such as rising costs of cancer therapies, energy, pharmaceuticals, labor, and compliance with state mandates like the 2030 seismic construction mandate. We have already committed and nearly completed almost $2 billion of work to comply with these mandates and have an additional future cost estimates that exceed $1.5 billion. Additionally, Medicare payments are not reasonable and should not be considered as a baseline. Scripps faces significant shortfalls in Medicare services to the tune of more than $400 million last fiscal year. While we support the mission to control healthcare costs, it should not come at the expense of access to the quality of care. We urge this board to consider the real-world impacts of its policies on providers and communities. At Scripps, we remain dedicated to delivering quality, safe, and cost-efficient healthcare. Thank you all for your time.
Thank you. Looking back to the podium, seeing no one at the podium in the room, looking online, noting for the record, we have about 118 virtual attendees and 3 hands raised. Gary, you are next. You should be unmuted. Go ahead.
Thank you. My name is Gary Ray. I'm Chief Legal Officer for Salinas Valley Health. Salinas Valley Health is very concerned about the recommended sector target values released late last Friday. We're extremely disappointed that the recommendations that the board is considering today completely ignore the financial facts that Salinas Valley Health operates an integrated healthcare system, not just a hospital. The sector targets also ignore the burden of our local payer mix, as well as a potential dramatic shift in future Medi-Cal funding. Salinas Valley Health has repeatedly pointed out to this board the complexity of healthcare financing and pricing. This complexity is apparent from the significant and frequent changes in methodology for assessing healthcare expense outliers. However, it appears that OCA is now ready to push forward with a good enough approach that will have significant consequences in our community, compounding existing health disparities in the population we serve and undermine years of progress in expanding access to quality care. In our recent conversation with a number of OCA representatives, there seems to be a general understanding of the important advances Salinas Valley Health has made addressing affordability and access by building a 1206B clinic model to enable providers to care for the district patients. Although these expenses are entirely excluded from HCI filings and Medicare cost report, they represent a significant financial burden on Salinas Valley Health system. Salinas Valley Health has continued to absorb these costs over the years in order to meet all the healthcare needs of all patients in our community. While the value of the clinic relationship and benefit to our community was acknowledged by members of the OCA board, our recommendation to consider financial data as simple as annual audited financials for the healthcare district was considered too difficult to assess. Instead, the OCA board is choosing to pursue a methodology which is flawed and does not consider system costs, hospital and clinics. Despite the most recent assessment identifying the need for approximately 40 additional primary care providers in the Salinas Valley service area, Salinas Valley Health will be forced to consider discontinuing these recruitment efforts because those costs are not accounted for in the OCA analysis and are unsustainable under the OCA recommendation.
2 minutes.
As a vital safety net provider in our community, the recommended sector targets will have a significant impact on our ability to serve the Medi-Cal population. If the recommendation is adopted, Salinas Valley Health will need to consider restricting access for Medi-Cal patients simply because OCA does not account for the enormous expense these patients have in our system. Over 40% of our community relies on Medi-Cal coverage, and changes could impact more than 200,000 patient encounters annually for these essential services. OCA's decision not to evaluate Salinas Valley Health as a healthcare system will unavoidably have a negative impact on our ability to maintain and expand these essential healthcare services for those who need it most. Thank you.
Thank you. As a reminder, this public comment period is for the agenda item executive updates, and we encourage everyone to limit their comments to that agenda item. We will have a general public comment period. Looking online, Craig Partridge, go ahead.
Hi, yes, thank you. My name is Craig Partridge, Vice President of Payer Analytics, and I'm here on behalf of Dignity Health, the largest provider of Medi-Cal services in California, operating 29 hospitals statewide and a critical part of the state's healthcare safety net. Thank you for the opportunity to speak with you today. We are here to express concerns. Patients' access to care is at stake, as is the financial health of California hospitals. And we urge the office to compile a more thorough and comprehensive approach when attempting to manage healthcare costs through OCA's spending targets. So 3 key points. Number 1, the dynamics between commercial and government. A approximately 3 out of 4 patients, 75% of those who come to Dignity Health rely on Medi-Cal or Medicare products for their healthcare coverage. Government reimbursement under these programs falls far short of covering hospitals' costs. For Dignity, this dynamic resulted in over $245 million in losses last fiscal year. By focusing solely on the commercial year-over-year revenue caps, the office is missing the complete picture and does not solve the underlying problem, causing commercial rates to necessarily bridge the gap. Number 2, the impact of physicians and IDNs on hospital finances. In many regions, our hospitals are underwriting the significant costs and losses attributed to the physician network. Santa Cruz County exemplifies this situation. The HCI hospital reporting will not provide insight into these physician costs, and thus focusing on hospital finances in isolation misses the true financial scenario. Number 3, hospital cost inflation, as has been touched on by others. Hospital expenses continue to trend at elevated levels, and this does not appear to be abating anytime soon. From our fiscal year 24 audited financial statements, salaries and benefits rose 6.4% year over year, supplies 6.1%, purchase services over 8%. These costs are not atypical, as was just validated by a recent Kaufman National Hospital flash report showing labor trending at 5%, supplies at 9%, and pharmaceuticals at 9%. Healthcare affordability is a shared responsibility across the industry, and we take our part very seriously. We look forward to continuing to partner with the board and staff to achieve a sustainable and comprehensive approach to revenue and cost management. Thank you.
Thank you. Looking back in the room, seeing no one at the podium, going back online. Stacy, you should be unmuted on our end. Go ahead.
My name is Stacy Bratcher. I'm Senior Vice President and Chief Legal Officer for Cottage Health, which is located on California's Central Coast. We are the sole community provider in the southern part of Santa Barbara County. We operate 5 different hospitals and medical centers. The only level 1 trauma center between Los Angeles and Stanford. As many others have said, we rely pretty much on government payers. 75% of our payers are Medicare and Medicaid. We are incredibly concerned about the changes in Washington and at the federal level and what that might mean for Medicaid instability here for us in California. As I mentioned, there is no public safety net here in Santa Barbara or in our county. So Santa Barbara Cottage Hospital, Goleta Valley Cottage Hospital, those serve the sickest of the sick and the poorest of the poor. Our health system offers charity care and discounted care well above the mandated amounts that the state has. We offer discounts to folks that are up to 700% of the federal poverty limit. We offer residency training. We have 4 different resident training programs that are underfunded. We have invested in services that are not adequately reimbursed. This includes psych services, pediatrics, primary care, urgent care. I would argue that we're one of the few providers that accepts Medi-Cal at our urgent care centers. These services and others will have to be looked at very closely if we are not able to have more flexibility in our rate arrangements with the private commercial payers. As others have said, and I know it's not a popular sentiment, but the truth is that the government payers do not cover the cost of healthcare in California or elsewhere. And so the only way we're able to make ends meet is through commercial arrangements. Again, we are very concerned about the instability at the federal level and what that might mean for us on a larger level. In the last 3 years, we've had a negative operating margin and have only been able to close the gap with extraordinary measures such as fundraising. So with that, I'll yield the time and just let the OCA board know that we are opposing and have a lot of concerns with the spending targets. Thank you.
Thank you. Looking online, seeing no hands raised, looking in the room. No one at the podium. That concludes public comment on this item.
Okay, thank you. With that, we will move to item 3, and I'll turn it over to Deputy Director Pagani.
Thank you. We just have the meeting minutes from January, and they've been distributed as part of your meeting materials.
Questions or comments from the board on the minutes? If not, we will take public comment on the minutes.
You can go ahead and do a motion, and then we'll move to public comment.
Move approval.
Is there a second?
Second.
Okay, motion moved and seconded. Public comment?
Thank you. We'll now take public comment on this agenda item. Please step to the podium or raise your hand. I'll give it a moment. Seeing no hands raised online. And seeing no one at the podium, that concludes public comment on this item.
Okay, let's take a vote.
Dr. David Carlisle,
Abstain for absence.
Dr. Sandra Hernandez,
Aye.
Secretary Kim Johnson, Richard Cronick,
Approve.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Dr. Richard Pan.
Aye.
That's 4 ayes, 1 absent, 1 abstain. The motion passes.
Great, thank you. Now let's move on to item 4A, OCA's recommendation for hospital sector target methodology and values. I'm going to turn this over to whom?
To me and Assistant Deputy Director CJ Howard and Andrew Farrer will be co-presenting this with me. So in this next section, we're going to share OCA's recommendation for a hospital sector target methodology and values. Next slide. So before we do that, we just want to have a chance to address 4 follow-up items in response to board member questions from January. The first ask was that OCA meet with hospitals and collect feedback on the presented methodology for identifying high-cost hospitals. The second ask was that OCA project how many years it might take for high-cost hospitals to come in line with the 80th percentile. The third ask was that OCA examine the distributions, not just the percentiles of the unit and relative price measures. And then the fourth ask was that OCA compare CMS federal hospital price transparency data and the HCI annual financial data. Next slide. With regard to the first board follow-up item, Vice Chair Hernandez asked if OCA could meet with hospitals and collect feedback on the methodology presented for identifying high-cost hospitals. To address this request, we met with 5 hospitals between the January board meeting and today's meeting. We met with the 5 hospitals listed here. OCA's discussion with these hospitals included receiving an overview from the hospitals on their facilities, operations, and programs. We requested feedback on the proposed options for identifying disproportionately high-cost hospitals that may merit a lower spending target value. And then lastly, we asked for suggestions for different measures OCA could consider to identify disproportionately high-cost hospitals. And the feedback that I'll present is what we received to date from 5 hospitals. We're going to continue to meet with more hospitals in March and relay that feedback at the next meeting. So moving on to the next slide. So in terms of the thematic feedback pertaining to identification of high-cost hospitals, we received some feedback to, rather than have a list of 10 or so hospitals, we received a recommendation to consider the top quartile of all California hospitals, which would equate to the 75th percentile. And then the reason noted was that singling out 10 or so hospitals will not bend the overall cost curve, and there was a suggestion to increase the number of hospitals. There was a suggestion to consider excluding disproportionate share hospitals. Also a recommendation for adjustments for academic medical centers, as they often serve fundamentally different, or they often have fundamentally different organization and staffing structures with many specialists. Do not use a methodology that preemptively excludes 50% of California hospitals. So this was referencing our discharge threshold that we applied to the approach presented in January. Comments received also pertain to evaluating at a health system level rather than individual hospital. A hospital may have high margins, yet the hospital may incur costs outside of the hospital, but within its system, for example, for clinics, that potentially have much lower margins. And lastly, for identification, there was a suggestion to use operating margins for health systems to identify outliers, not operating margins of individual facilities. And then moving on to the feedback for unit price measure, there was a suggestion to use the combined average across all payers for case mix adjusted discharge instead of focusing only on commercial. There were comments pertaining to the case mix index adjustment and how, while it does measure intensity, there was a critique that it doesn't adequately account for quaternary care, in which patients stay longer than 30 days. And then a comment was also made that CMI does not consider all costs of care, and an example was given about transportation costs for organ transplants. And then lastly, unit price measure does not account for the costs some hospitals incur. For example, capital expansion, existing reimbursement levels would make it difficult to justify investments for regulatory purposes and expansion. And then on the next slide, with regard to the relative price measure, which is the commercial to Medicare ratio, there's a suggestion to avoid using this ratio and just use the combined average across all payers for net patient revenue per case mix adjusted discharge. Another hospital recommended revising the way we're calculating relative price, and they suggested only to include Medicare fee-for-service or traditional Medicare in the calculation. And the reason they provided was that capitated rates for Medicare Advantage are not adjusted for area wage index or teaching status. There's also no standard methodology of how systems allocate capitation revenue to hospitals. And then they suggested that these changes would account for those hospitals who are in more heavily capitated arrangements than those who are not. And then another recommendation was to use the experience of Massachusetts, which created a relative price measure out of their APCD. There's a suggestion to use our health care payments database in a similar fashion to have a more accurate picture of actual payments, but they noted that this would take some time to develop. And then moving on to repeat outlier, which was our approach of looking at 3 out of the 5 years. One entity agreed that this was a good approach. Another entity preferred the use of a pooled average across the 5 years. And then lastly, regarding payer mix threshold, some agreed that a threshold of 5% revenue for both commercial and Medicare was reasonable, while others indicated this is not a sufficient percentage, but they did not recommend an alternative. And then on the next slide, I'll just cover some general feedback and comments, and then we could pause for questions, and then we could go on to the other follow-up items. So other feedback we received was caution should be exercised when determining who is a high-cost facility. There was a suggestion to delay the sector target to allow for the COVID-19 pandemic numbers to not be included in the 5-year averages. A comment was made about Medicare reimbursement going down and higher commercial is needed to support hospital operations. Another comment specifically talked about the relative under reimbursement of physicians in Medicare and how this drives a lower commercial reimbursement. And then another comment was made about aggressive pricing caps will have unintended consequences affecting access to care. A general comment was made pertaining to OCA and the board should not rush to just do something, instead be measured and deliberate. And then additional comments were made about consideration being needed for high cost living areas, including wages and benefits of employees, comments about clinical innovation, investments and expansion of services that require high upfront costs, research conducted by academic medical centers, which is much more advanced and may be funded in whole or in part by clinical revenue. There was a comment about efforts to coordinate care through increased use of APMs, such as capitated payments, and consideration being needed for that. There's discussion about future federal actions, such as increased tariffs, proposed cuts by federal policymakers pertaining to Medi-Cal and Medicare, which will ultimately affect payments to hospitals. There was also discussion about considering the complexity of specialty pharmacy costs and pass-through charges and the need for hospitals to maintain positive operating margins, and lastly, the need to consider payer mix. I'll just pause here just so we could get any board comment before we move on to the other board follow-up items.
Elizabeth? Rachel?
Thank you. Two things. First, thank you for doing this. I think it is really important to get recommendations from the industry who say they would like to help. Would you characterize any of the input as alternatives to what we're doing? So is there any solution on how to reduce commercial costs? Because all I've heard is that they have to keep shifting more to commercial.
We didn't, that was a recurring theme about kind of the cost, the effort to control costs will take time, but we specifically focus more on the methodology of how we're identifying the high cost hospitals, and not so much on the dynamics of the cost shifting.
But there weren't any ideas or recommendations on how to reduce costs to commercial?
Not specifically. No.
Okay. Thank you. My second question is separate, but are you looking at the TIC data, the CAA data that shows negotiated rates? Because there was some suggestion that we can't get visibility into that, but we are actually doing a data project right now that shows that it is entirely possible. We're seeing the negotiated rates through the TIC data combined with employer data and then compared to the hospital reported data. So I believe that is much more achievable than people may understand, not necessarily directly from like the vendors like Turquoise who don't have the employer data, but once you combine them, you can actually see the rates and the variations across facilities. And it's quite usable. So that I think that should be something we consider.
Yeah, we have a slide on that and would welcome further input on that.
Dr. Carlo?
Thank you, and I also want to express my appreciation to the hospitals that participated in providing feedback as well. Technical point, Vishal, could you comment or elaborate more on the Massachusetts recommendation, this method for a relative price measure? Is it something that I think we've discussed it a little bit, but could you say more about it?
Yeah, they use their APCD to do kind of a relative price, and they report this. I believe they index it to like 1, and then they kind of report by types of hospitals and how kind of how their pricing is relative to each other. We are having David Seltz from Massachusetts speak in March, so we could ask him to speak about their work in that area.
Dr. Pan?
No, thank you for the presentation, and really appreciate that you have met with the hospitals, and I understand you're going to be meeting with even more. So I think this is going to be very helpful information. I know our last meeting we talked about systems, and in fact, actually, in the original legislation to establish this office, there is one system that said we don't. We operate as a system, and therefore you should only look at us as a system. So that's even explicitly in our legislation. So this comment, of course, has come up again, and we talked about it last meeting. And I think I think the thing is in terms of looking at the overall ecosystem, right? So obviously, a hospital does not operate in isolation. And it's possible the hospital, again, possible, you have to examine what the circumstance is that in order to maintain access in the community, not only to the hospital, but the healthcare overall, the hospital may play a financial role helping support whether it's clinics or practices or other types of things. And, obviously consolidation has its own issues. We've talked about that, but also there's a role sometimes hospitals play in that part. I think it was noted, actually Medicare payments for physicians is going down. It's not level, going down, despite the fact inflation's going up. So I guess, and the comment was made here, in terms of how do we look at the role, that potential role the hospital plays, right? Now, even if they play that role and they're like raising prices and they're basically pocketing a lot of money, that's an issue for us, right? But if basically they're playing that role to help support the ecosystem, which then allows people to have access, and we only looked at the hospital part and said, well, we're not looking at what they're doing there, then we could actually reduce access and quality in that community. And so I guess the question is and it obviously came up, how are we going about examining that aspect of of the role the hospital's playing. So I think that's an important point that's come up that we've talked about before, that we need to continue, whether there's some component to look at that particular role. I guess the suggestion of one was like, obviously we have facility specific information that comes to the state, but also maybe some sort of approach to also look at, okay, what is your overall as a system if you own or you have these practices, how's that going? Because if for example and we talked about even outpatient and how we measure that and the lack of data there, but if that's part of what the role of the hospital is doing, then we at least need to know what impact that we may have on that, because that would affect the whole community.
Thanks very much, Dr. Pan. And we definitely heard from hospitals who want a wider consideration that, they may be supporting. We have a hospital who's concerned because they say a significant portion of their revenue is going to support outpatient clinics. Mm-hmm. So we've certainly heard that perspective. I think, at this point, different hospitals have made different choices about what their legal structure is like and how they've chosen to include or not include certain components. And so at this point, what we have, of course, is the hospital is the entity as they've chosen to legally structure themselves, and the reports that the financial reports that they've submitted to us. Now, we don't currently have the ability to measure by system unless they've themselves chosen to do that, with the exception that you note in the bill. Yeah. So we've certainly acknowledged that it's something that we could look at on the back end, but in terms of the front end review, what we have is how they've chosen to structure themselves and how they report their hospital financial data. Okay.
So I guess what I'd say, and I realize we're not quite at that point in the discussion, but put a pin on there is that, and I think we touched a little bit on the last meeting, we need to set some well, first of all, it needs to weigh in at some point in time, right, before anything happens to, and how and what the process by which that will happen, and also maybe some indication as to how we're going to go about doing that. I think it's going to be important. So, if we can't do it on the front end, do we do that on the back end before we go and impose penalties or corrective action plans, whatever else, and how we incorporate that into the decision making that would finally trigger some sort of action on the part of the office about that, and then or assign them, say, to make the final decision that that's you now have a new cost target because of that needs to be taken into consideration, I think, because again, I don't want to reduce access to care in a community because what happened is that people made decisions, yes, they different legal structures, et cetera, but that was before this office existed. And now what happens is we're basically saying that more rigidly telling people financially, you got to stay within this place, otherwise we're going to penalize you, because that's what we can do. And so I think that's going to be important, that we don't basically harm access in communities because of that. Obviously, we're trying to improve affordability, but if we improve affordability the one piece, but then we do reduce access in the others, that is not going to be productive.
Yeah.
So.
And I'll just say, I was not able to sit in on all of the meetings, but I did sit in on some of them, and it was very helpful. And to Board Member Mitchell's point, this hospital, for example, that asked us to consider their outpatient clinics, didn't have a specific proposal of how we would capture their data. So I think it's something that we need to have ongoing conversation about.
Yeah, it did look like in the notes, and I appreciate that there was some appeal to say, like, okay, let's to actually look at the, I guess, and again, obviously different legal structures be differently, but is there a way to say that beyond the actual facility itself, and is there some sort of a way to basically look at the performance of the whole system, right? Obviously, depending on the legal structure and so forth, and maybe it's incumbent on I guess the system that the hospital's in to provide some kind of financials or reports that they also make public about that.
And they did talk about that, and then that would just I somewhat misspoke. So they did talk about wanting to submit all of their financial reports, which we don't currently have, again, on the front end, the ability to take that in. But it's certainly something we're looking at.
And then one other question, because you mentioned about teaching hospitals, is on the Medicare, when we do the ratios, is because again, indirect medical education adjustment, is that in or out in determining the Medicare rates for the hospital? Because
it should be in.
It would be in. Okay.
Yeah.
All right. Well, as a GME financing guy, I'm trying to decide whether that's a good or bad thing, because what happens is that it's a proxy, but it's very tied to the resident to bed ratio, and of course the percentage of Medicare that the hospital has. So if you have a lot of residents and fellows, that really bumps up your Medicare rate. If you have a few or none, it does. So it's a proxy that is a somewhat imperfect one, I think. So anyway, okay, that's helpful to know. Thank you.
Elizabeth, did you want to get in?
Thank you. This is specific to the question around measuring systems. So if we were to do that, would we look at the costs of other facilities like practice, any sort of outpatient practice once it is acquired? And could we insist on site neutral payments so that, because one of the trends that we're experiencing is when a practice or specialty or whoever is acquired, then they just increase pricing. So I would want visibility into that if we look at systemness.
We have a lot of ifs before we get there, but certainly hear the point, right? Because we would first need the legal authority to collect data by health system. Then we need to set up the infrastructure, develop the regs for it, and hear your point. Thank you very much.
Ian, and then Richard.
Thank you. This is a follow-up to Dr. Carlisle's question, and maybe to put off till March, but with regard to I was also intrigued about the relative price measure, but mostly by comparison to the cost of delivering those services. We look at the Medicare ratio is imperfect as it is, but with all the adjustments that are built into it, it is the most standard, the universally recognized reference point. And we argue, does it take 50% more, 100% more than Medicare to pay the cost of care? I'm wondering if Massachusetts or any other OCA state has attempted to come up with a relative cost metric, getting at the question of what is a fair price.
Yeah, I'm not aware of any other state. Yeah, we're using the commercial to Medicare ratio because it's the best approach that we're aware of.
Richard?
Thanks. Just a comment and maybe a question. I'm struck by the sort of incongruity of the third and fourth bullets here, that for the hospital, Medicare reimbursement is going down and higher commercial rates are needed to support hospital operations. But for physicians, they're under reimbursed by Medicare, and that drives lower commercial rates. And, those are kind of opposite directions, and I can hypothesize and kind of understand maybe great stories about the reasons. But I wonder, was there any kind of discussion or recognition of what seems like a incongruity there?
Yeah, I won't speak for the hospital. Maybe the hospital that made that comment, maybe they'll address it. But I think the thinking behind that was the way that commercial tends to peg their reimbursement to a multiple of Medicare, that if Medicare is going to decline, then commercial will subsequently reduce prices for physicians.
Yeah, I thank you. And I'm sure I can imagine that the hospitals would then say, and they need to support the physicians to keep them in business. And so even more money needs to go from the hospital to the physicians. I can imagine that was maybe part of the discussion. But just to kind of take note of the very different dynamic here.
So go ahead, Dr. Penn. Oh, go ahead, I'll make a comment.
Maybe just a brief comment on, so I believe that in Medicare, physician payment is tied to cost neutrality. So if basically the way they determine what the physician reimbursement is, whereas the hospital apparently doesn't seem to be. So anyway, if the hospital had a bunch of practices, it'd probably be easier for them to try to get money on the hospital end perhaps than on the physician end. So that might explain part of it. But yeah, you're right. I mean, there's an incongruity there.
So let me appreciate the staff for going out and meeting with these folks, and to the hospital folks who sat down and had these conversations. Given that Assemblywoman Bonta has a bill now that's been introduced around systems, I might suggest that as we continue meeting with hospitals, that we begin to at least understand all the different varieties and flavors of systems that currently exist. Kaiser has a particular design. I suspect that if you look at hospitals, they have affiliation agreements that fund a little of this and a little bit of that. And if you look at the hospital down the street, it funds different things and defines systems differently. And so right now it's sort of a abstract concept that is being raised as a potential concern around access for other things that are going on in that community. But I think to begin to understand what are the designs of system and how integrated are they really, and how much of that really is an investment, for example, in primary care, where we have, of course, great interests, would begin to help us understand, even though we at this moment don't have a way to codify that in the analysis, at least to begin to look at the different kinds of designs that exist, so that we were Assemblywoman Bonta's bill to move forward, be in a better position to begin to take that into account in the methodology.
Yeah, thank you very much, Dr. Hernandez. And the team did put together a list of questions that we asked the hospitals that we met with, which started with for them to explain how they're organized. So I do think we are starting to get some insight, and we'll continue to do so. It's very helpful.
Yeah, and maybe at a subsequent meeting, we might look at a few of these models to begin to understand actually how they work financially, so that we are in a better position to think about methodology going forward. Okay, if there's no other comments from the board, I think we want to take, Dr. Pan?
Yeah, I don't know whether it's through OCA or HCI, whether, and I know you're meeting individually, and perhaps they're so complicated you have to sit down and talk to each of them. I don't know if there's any sort of survey of hospitals. Obviously, you collect thoughts about, trying to get some, I guess, typology, or what do you call it, for systems, right? Because that may be informative whether we're talking about, some of Vanta's bill, or just even for our own understanding, if that exists. So, basically, because you're right. I mean, and which ones which ones are actually relevant to what we're trying to achieve.
Exactly. So with that, you would like to hear a little public comment? Bless you. A little public comment? No.
Not
keep
yet.
going. Okay.
Yeah. So I'll turn it over to Andrew to cover the second and third board follow-up items.
Thanks, Michelle. And a quick follow-up to Ian's question. So there is a 2023 Massachusetts cost trends report, and so they do use 200%, so double Medicare's price, as what they describe as a conservative point of comparison as to what constitutes acceptable prices. And on we go to the next slide. So as part of the January board discussion around approaches for setting a cost target for higher cost hospitals, there was a request that asked OCA to project how many years it might take for those high cost hospitals to come in line with the 80th percentile should a cost relativity approach be used as the basis for target setting. And so what we did here to provide some insight into that question was use that commercial inpatient NPR per CMAD data for 2022. We then computed the 80th percentile weighted by inpatient discharges among comparable hospitals and assumed a growth rate between 3 and 3.5% depending on the year to coincide with the statewide spending target. And just for context, that 80th percentile in 2022 was around $29,400. Next, we would then compute the average for those 15 high-cost hospitals that were above the 80th percentile on commercial inpatient NPR per case mix adjusted discharge, as well as commercial to Medicare payment to cost ratios for 3 out of those 5 years, and then assume that 1.9% growth rate that was the output from that cost relativity approach. So for context, that pooled average for those 15 hospitals in 2022 was a little over $37,000. And then we just pretty simply linearly project outward until those two lines between the groups intersected. Just a note here, the reason for only using the unit price metric was that there's evidence for a diachronic increase over time during that 5-year time series, whereas the relative price metric remained relatively flat during that 5-year period. So we didn't necessarily want to take too many liberties here in this counterfactual exercise. So we can go to the next slide. Okay, again, just a caveat, this is a highly stylized scenario, and so we're not going to bet our mortgages on it, but just to give some insight and trying to be responsive to that question here. When we look at that average inpatient commercial NPR per CMAD for those hospitals above the 80th percentile and project that growth out at 1.9%, compared to that 80th percentile growing at between 3 and 3.5%, it would be approximately 20 years, give or take, before those high-cost hospitals were to come in line with the 80th percentile. And then we can go on, if there are no questions, we can move on to the penultimate board follow-up item on the next slide. Okay, great. There was also a request from board member Pan that requested looking into the distributions of those two cost metrics in lieu of simply the percentiles that were previously reported. So in this table, there's a fair number of descriptive statistics here. So we include, per Dr. Pan, one standard deviation above the mean, as well as the average across those two cost metrics over that 5-year period, the 80th, the 85th, and the 90th percentile. And then just given, as you'll see on the next slides, the non-normal nature of these distributions, there's an alternative approach for outlier detection using two key outliers. So the basic approach here is to rely on the interquartile range and develop some multiplier for some set of values above or below that interquartile range. And so here you just see those range of values to just provide a little bit more context in those distributions. And then the next slides will go into a little bit more detail just to kind of help visualize what those histograms look like. So you can see here, we plotted for edification just to understand that there's a fairly long tail associated with unit price during that 5-year period on average, but we did include vertical lines, the closest to the y-axis being the 80th percentile, the one in the middle being the 85th percentile, and then the furthest from the y-axis being that 90th percentile. So those ranges between 27,800 up to 33,400 for the 90th percentile. And then going to the next slide here, we'll include the same histogram for the relative price measure with those same 3 lines to denote the 80th, 85th, and 90th percentiles. And you can see there they range from between 265% to a little over 300% during that 5-year period. If there aren't any other questions on these 2 items, I'll pass it back over to Vishal.
So I'll be covering the 4th follow-up item. Board Member Mitchell had asked us to look into the CMS hospital price transparency data, and we just provided a comparison to the HCI data. So this slide shows a description for these 2 data sources and the advantages and limitations. For CMS hospital transparency rule, data hospitals are required to self-report gross charges, payer-specific negotiated rates, and cash discount prices by service for all services, and they post it on their hospital website in a comprehensive machine-readable file. And then there's also a separate file that they submit, which could be a cost estimator tool or some other consumer-friendly format for self-reported gross charge, payer rate, and cash prices for 300 shoppable services. So a potential advantage of this data source is that it includes gross charges, payer rates, and cash prices for all items and services a hospital may offer. That allows for public analysis. Another advantage is that it includes the charge rate and price information for 300 shoppable services, and then many of them offer it in a cost or estimator lookup tool. Some disadvantages of this data include that it's not available prior to 2021. It may be difficult to locate on a hospital's website. Not all California hospitals may be in compliance. A study from 2021 notes that the compliance rate for California hospitals was around 24%. There's also variations in the form and formats of these data prior to July 2024, which complicates doing a apples to apples comparison. Service volume isn't included, so while it's great that prices are included, we don't have the volume information to calculate total spend, but would be interested in hearing from Board Member Mitchell about how employer data is being combined with that. And then just turning over to the HCI annual financial data. So for this data, hospitals self-report general information, information about their ownership, medical staff specialties, service inventory, utilization data, balance sheets, and other categories listed here. Some advantages of this data set is that it's publicly available from 2012 to 2023, and it contains data on all California hospitals in a standardized form and format that aids comparison within and between hospitals. So when we compare the data, when compared to data a hospital is prepared to comply with the CMS hospital price transparency rule, the disadvantage of HCI financial data is that it does not include the gross charges, payer rates, and cash prices for a hospital's items and services, or data for the 300 shoppable services. And yeah, that's kind of the gist of our comparison, and would be happy to turn it over to Board Member Mitchell in case she has other comments.
Thank you for doing this. I think it sort of really underscores the fact that none of these data sets are adequate on their own. I think, not knowing gross charges, payer rates, and cash prices, as an example, is challenging. So I don't think it's appropriate necessarily for today, but I think the staff could also consider the TIC data, which shows the rates. It's a combination of the data that makes it most useful: claims, employer, TIC, hospital reported, and then we're also using, quality and safety data. But I'm happy to talk further about that. I want to make sure we are taking full advantage of the data that is now available, even though it just became available in 2021. That was the result of considerable effort. So would like to make sure we leverage that, because I think it does give us really important information that is not otherwise available.
Dr. Pan.
Actually, I was wondering if I could just ask a question about the histograms. So if we want to finish this, if there's anyone else, and then we can go back to that.
Why don't we go back to that? Go ahead, Dr. Pan.
Okay. No, I appreciate the staff doing the work following up to the question I had. What's curious about to me, well, first of all, of course, we note that there's a skew, right? There's a tail there. Obviously, the other end, it's sort of capped at 0, but it's interesting that this histogram, which is the commercial to Medicare, it also looks like it's two-headed. I mean, obviously it's a gross looking at it, compared to the previous one, which, looks more like at least partially like a more closer to a bell-shaped curve with a skew, right? So is there any thought as to why this one, is there something different about the hospitals that mainly are in that one head versus the hospitals in that other head there? It seems like an interesting distribution. That's all. So, and is there any insights that we might glean from that in terms of using the, I guess this is the commercial to Medicare PTCR. Yeah, so I just find that to be an interesting distribution to look at.
I don't have necessarily any speculation as to what may precipitate that sort of bimodality. We can provide some additional information on the hospitals that tend to be below 200 versus above, but that would be the extent to which I would be inclined to speculate today.
Okay. Yeah, it's an interesting curiosity in looking at the distribution and sort of trying to understand what's underlying that distribution. So,
Richard, do you want to comment?
Yeah.
As you're looking at it, a hypothesis would be that the hospitals that are at the lower end are more likely to be public hospitals and hospitals with high fractions of Medi-Cal. That may not be true, but that would be my guess.
Yeah, I think, okay. I think it'd be interesting to look at least a few things like, for Medi-Cal, even maybe over there, does anything about proportion of Medicare? So, because we're doing a ratio, commercial to Medicare, right? If you have less Medicare, how does that affect the ratio versus you take more Medicare, and then same with the Medi-Cal? And so I think if there's some ways to at least do a few checks on that, see if there's any that seems to be driving that, it might be helpful.
Let me welcome Secretary Johnson, who has now joined us for the meeting, and I'll hand the program back over to her.
Thank you so much, and good morning, and apologies for being late here and being double booked. Sounds like we are in the follow-up items from our previous conversation as we're turning into the broader. I just wanted to take a moment just to, as one of those follow-up items noted and that you likely just discussed, listening in on the kind of perspective of hospitals in terms of how they see the expenditures and where we can continue to improve upon, to the conversation that was just occurring, our totality of our picture and context. And so just want to appreciate the opportunity to have those conversations and dialogue, and also noting that some of that feedback also was in the context of the overarching uncertainties, particularly as they relate to potential action at the federal level. And want to just note that clearly, right, we are part of a very large ecosystem here trying to look at driving affordability, and want to just recognize that we are doing our very best to fulfill the charge and responsibilities that we have signed up for, and also recognize those other factors. So just appreciate the ongoing dialogue and conversation to ensure that we are utilizing the best information and best data and at the time to drive our ultimate decision makings, and a commitment to continue that engagement. So just wanted to start with that, and then maybe turn it over then to the team here for additional conversation on the recommendations.
We can move forward a couple of slides. So in this next section, OCA will provide an overview of its recommendation for the hospital sector target methodology and values. We'll move on to the next slide. The methodology has two key components: identifying high-cost hospitals and adjusting target values for those hospitals. And of note, I just want to point out that today's discussion starts a 45-day public comment window that will end on April 11th of 2025. The board will then have until June 1st to set targets for 2026 and can set targets for 2026 and beyond at that time. Move to the next slide. So OCA recommends selecting disproportionately high-cost hospitals that may merit a lower target value by identifying hospitals that are above the 85th percentile for 3 out of 5 years on both a unit price measure of the commercial inpatient net patient revenue per case mix adjusted discharge and a relative price measure of the commercial to Medicare payment to cost ratio. Additionally, OCA recommends excluding hospitals whose financial data is not available or comparable. As a reminder, those are Kaiser hospitals, long-term care emphasis hospitals, psychiatric health facilities, Shriners, and state hospitals, and those that do not meet a payer mix threshold of 5% gross patient revenue from Medicare or commercial payers. Based on board input, OCA did not apply or consider a discharge threshold in this analysis. So in our recommendations enumerated as follows: 1, OCA recommends identifying outliers as those that are above the 85th percentile. The 85th percentile approximates 1 standard deviation above the mean and the 2 key outlier methodology Andrew described previously. OCA recommends identifying repeat outliers on those measures that are above the 85th percentile for 3 out of 5 years on both the unit and relative price measures. Selecting hospitals that are outliers in 3 or more years identifies hospitals with systematically higher costs. We can move to the next slide. OCA recommends measuring unit price based on the measure commercial inpatient NPR per CMAD and the relative price based on the commercial to Medicare payment to cost ratio. Using both measures identifies hospitals that have systematically high costs. OCA recommends a payer mix threshold of 5%. A hospital's share of revenue needs to come from a broad payer mix for the commercial to Medicare payment to cost ratio measure to be credible. OCA recommends excluding non-comparable hospitals from the analysis. This approach identifies 11 hospitals as repeatedly disproportionately high-cost outliers. We can move to the next slide. This slide shows the individual values for commercial inpatient NPR per CMAD for the 11 repeat outliers for each year from 2028 through 2022 and the pooled average. The first 2 rows of the chart show pooled values for the 11 high-cost hospitals compared with all other comparable hospitals for the same time periods. 8 hospitals were above the 85th percentile for 5 out of 5 years, 1 for 4 out of 5 years, and 2 for 3 out of the 5 years. And the pooled average of 40.2 thousand among the 11 high-cost hospitals would represent approximately the 94th percentile in the distribution. Could move to the next slide. This slide shows the individual values for commercial to Medicare to payment to cost ratio for the 11 repeat outliers from 2018 through 2022, as well as the pooled average. The first 2 rows of the chart show the pooled average for the 11 high-cost hospitals compared with the other comparable hospitals for the same time period. 8 hospitals were above the 85th percentile for 5 out of 5 years, 1 for 4 out of 5 years, and 2 for 3 out of 5 years. And here the pooled average of 350% among the 11 high-cost hospitals would approximate the 95th percentile in the distribution. We can move to the next slide, where I'm going to start talking about some of the target setting. So OCA recommends setting the hospital sector target equal to the statewide target, to which they are already subject. Setting the hospital sector target equal to the statewide target just clarifies that hospitals in the sector are subject to the statewide target unless and until the board modifies the spending target for the entire hospital sector or specific hospitals within the sector. Move to the next slide. And here I'll get into the recommendations for adjusting the sector target for the identified high-cost hospitals. So OCO recommends the following steps for setting a target value for the identified hospitals that compares the identified group of hospitals that are repeat outliers on both the unit and relative price measures with other hospitals in the sector. So I'll walk through this, and then I'll also walk through it with the numbers on the next slide, and hopefully it will gel a little bit then. So the first step in this is to divide the identified high-cost hospitals' average commercial inpatient NPR per CMAD, weighted by the number of inpatient discharges for the 5-year period, by the outcome of all other comparable hospitals' average commercial inpatient NPR per CMAD, weighted by the number of inpatient discharges for the 5-year period. We would divide also the identified hospital's average commercial Medicare payment to cost ratio weighted by the inpatient discharges for the 5-year period by the outcome of the average of the, for all other comparable hospitals, average commercial to Medicare payment to cost ratio weighted by their inpatient discharges for the 5-year period. We then average the outcomes of steps 1 and 2 and then divide the current statewide target by the outcomes in step 3. We could go to the next slide. So here's how all of this works. In A, is the weighted average commercial inpatient NPR per CMAD for the high-cost hospitals, which is $40,200. We have the weighted average commercial inpatient NPR per CMAD for all other hospitals, which is $20,200. The cost relativity then for the commercial inpatient NPR per CMAD is 2. It's simply A divided by B. We repeat the same method for the commercial to Medicare payment to cost ratio. For the high cost hospitals, the average is 350%. For all other hospitals, the weighted average is 200%. The cost relativity for the payment to cost ratio is 1.8. The average then of 2.0 and 1.8 is 1.9, so that's their combined cost relativity across both metrics. There was some discussion about why we were only incorporating one metric in our presentation in January, so this is our attempt to use both cost metrics in the methodology for target setting. Excuse me, seeing both metrics were also used to select and identify high-cost hospitals. So then to calculate the recommended high cost target value by performance year, we take the statewide target and divide it by the combined cost relativity. This would yield 1.8 in 2026, 1.7 in 2027 and 2028, and 1.6% in 2029. We can move to the next slide.
CJ, would you like us to hold on? There's a couple of questions so far. Would you prefer to go through it, or what's your preference?
We're almost done.
Okay.
So if it's all right. Although my throat would, of course, enjoy a break. Yeah, so in this slide, repeating the analysis that Andrew presented earlier, we simply tried to project forward what would happen if the 85th percentile value grew apace with the recommended target values. Beyond 2029, we straight-lined at 1.6% growth for the 85th percentile and straight-lined at 3% growth for at 1.6 for the high-cost hospital, the average of the high-cost hospital outliers, and then we straight-lined the 85th percentile at 3%. And it would take approximately 20 years for these two lines to intersect or come in line with each other. Okay, so under the status quo, the high-cost facilities would continue to grow at or below the statewide spending target, but are doing so from a higher baseline level. Further limiting the rate of growth for these hospitals would bring the costs incurred by consumers for these hospitals more in line with the broader hospital sector, thereby reducing historical inequities between high-cost facilities and more efficient facilities. The impact of the slower rate of growth is that savings would lead to more equitable access to high quality and affordable care for Californians, and rooting the adjustment methodology in the statewide target underscores the principle of consumer affordability, as the statewide target is based on median household income growth, a key metric of consumer affordability. Last slide before we get to the final. OCA recommends aligning the adjusted target values with the current statewide spending target schedule for 2026 to 2029. A multi-year target provides hospitals long-term predictability. Knowing the target value in advance encourages cooperation within the healthcare industry to meet targets and allow the targets to influence negotiations for contracting and inform strategic planning and operations. In the event of extraordinary circumstances, including highly significant changes in the economy or the healthcare system, the board may consider changes to the target. NOCA recommends that the board meet annually to consider any needed updates to the target. The next slide shows the identified 11 hospitals along with the targets per year. And at this point, I'll turn it over for questions and discussion.
Don, please.
Thanks. Just a question about this going, maybe if we can go back to the list. So it looks like I just couldn't help but notice North Bay, and which was doing not very well and now is doing a little bit better than the state average. And it seems like they would have the reduced spending target apply to 165% Medicare growth rate, which seems problematic. There may be a smoothing piece in here that I'm missing.
So we've reached out to North Bay to have further discussions to understand more about the operations and are digging into that as well.
Okay, but just hypothetically, if we're using this methodology where it's 3 of 5 years, and you see significant improvement in the last 2 years, if that's just hypothetically accurate, what do we do with that?
Yeah, we're still we're trying to schedule a meeting with North Bay, and that'll happen this month.
But I'm asking a hypothetical question, so it shouldn't matter what North Bay. I mean, just suppose for the sake of argument that that's an accurate trajectory. What are we doing?
And we'd welcome board suggestions on that as well, Don. If you.
Yeah, I mean, I would say it's a problem to be applying a reduced spending target for to an entity. I mean, that's my initial reaction to an entity that over the last couple of years has seen significant decreases in their spend. And more to the point, like if we're going to include a certain number of hospitals, maybe there's a better target than one that has that trajectory.
Yeah, but before we would do that, we'd want to, because the drop off between 2020 and 21 is pretty, we'd want to confirm
that. It's very odd. Yeah. It's just, I mean, that there are going to be some, presumably, I mean, especially as hospitals are responding to the spending growth targets, we're going to see some that are still high, but that are trending better more quickly than others. And it seems like that should be a consideration as we're looking at the potential of a reduced spending growth target, if we see that kind of improvement more organically.
So improvement in more recent years is what.
Yeah, I mean, it's capping spending growth at 1.8 or 1.7 at 165 when it's 165% seems. Yeah, maybe I'm missing something.
There is almost certainly something wrong with the data, either in the earlier years or the later years, or something incomparable. And I think finding that out, as it sounds like staff is working on, is needed before, you know, can figure out what to do.
Yeah, it does. It still raises a larger question, which is what do we do when we see an improving trend, and more to the point, the closest years with pretty good trend, but bad trend in the more distant history.
Yeah, I agree. I mean, while there may be imperfections in the data, it's the same data we're looking at everybody. I mean, it's the data source. So obviously, if we know that's bad data, that's one thing. But I think trend is important. So I get the 3 out of 5, but trend does matter. And, you know, especially, I mean, basically, the bill wasn't passed until midway through this. So it's not like they responded to the legislation and they started to. So anyway, I think that if someone's trending and basically where they're at right now is, I think there's some question as to whether it makes sense. And then also, of course, as people respond to our our actions, we should take account of, to a certain degree, of trending, right? I mean, if they're really high and they got a little lower and they're still really high, well, maybe still. But if, you know, I do think, and also if someone's trending the wrong way, right, we might actually want to jump on that a little earlier. So I think, you know, it goes both directions. So I do think, you know, I think it's certainly North Bay seems to be an example, and Marshall maybe less so, but still, you know, you see that also their last 2 years for one, and then last year for the other. So is it, what's the, you know, what is it an ongoing trend or not? I think that's something. The other question I have also is that I sort of get the logic of how you're trying to come up with the identified high cost hospitals, but in some ways the logic for that formula, well, one is we have a discontinuity because basically, literally, there's a cutoff, right? If you tip over and you got the 2 out of 3, you suddenly drop, right? It's not, and so there's some people who are just probably below that, you know, just missed being in high cost, and they get to get 3, and then if you're just over the other way, you potentially, and so there, you know, whether we want such a discontinuity, I don't know. And then the other question is that while I kind of understand the logic we're trying to pull off with this formula, you know, of all the people who are in this high cost pool, some are higher than others, and whether this kind of approach should be applied, maybe not just pulling them all together and saying now either you're in the 3.5 cost target or you're in the 1.8, I think was it, cost target, or is there, you know, again, you know, I think is there some thought about, because even within the high cost folks, there are some higher than others, whether instead of creating like, and then if basically you're in one category, you have one pool and another one, that there's, okay, if you're closer to the line and you're et cetera, based on your numbers, you know, versus if you're way off, we're really, you know, it comes down even more using the same formula approach or something like that. And again, you know, we're sort of weighting both of those equally, right? We take one and we take the other ratio, and then we take the average of the two. But just some thought as to whether we're just basically 2 categories. You got one cost target for one cost target for the other, or is there some sort of, you know, are they all the same basically? If you're in the high cost, then are you basically so anyway, just something to think about in terms of the application of the formula.
Ian?
Thank you. My gut, as Dr. Kronig pointed out, like it certainly seems like there's a data problem here, but you're doing your due diligence to figure that out, and I have no doubt you'll suss it out. If hospitals respond to this in a way that actually results in coming down to more normal levels from an outlier status like that, I mean, I will consider the OCA experiment a resounding success, and we should, I mean, they'll meet their targets with no problem, and we should have them here at a pedestal learning from them. So I really look forward to that day.
Right.
Oh, and I just point out 20 years from now, 2045, these hospitals could still be outliers at the 85th percentile. This is not a radical intervention into the market.
I mean, yeah, sorry. I mean, yes and no, Ian, because I mean, they're still subject to a 1.8% and 1.6% spending growth target at 165% of Medicare. So that's, I will, just a follow-up question on your authority. So I know that you have the authority to listen and to adjust any enforcement action with the normal spending growth targets. I'm assuming you have the same flexibility with the reduced spending growth targets, right?
Correct.
Okay. So maybe the right answer here is that should be something that you take into account as you're talking to, I don't want to keep on picking on North Bay or doing the opposite of picking on them, I guess. But you know, in a conversation with them, if I were North Bay, I would point out that, you know, they're now at some much reduced level, and that would be something that presumably you would factor into your decisions about enforcement actions, right?
Yes, I think it's an important point, John. Thank you.
Okay, so that, I think that's maybe helpful as we're thinking about these.
I guess I might go even further if you have the authority that you know, if in the case of North Bay, the earlier data, the 2018 to 2020 data are incorrect in some way, then I would hope that you have the authority and flexibility to not have North Bay on this list to begin with. And if it turns out that the 2021 and 2022 data are incorrect, then some correction there is needed. But if I could just, while I've got the floor, you know, I think Dr. Pan makes, you know, good points. You know, having cliffs in formulas like this is never desirable. We saw that in the ACA around the 400% cliff, and they've kind of, you know, that was partially fixed. Having the same rate for every hospital and the administrative costs of having separate targets for, you know, 11 different hospitals is obviously kind of harder to keep up. And I think the argument for sort of getting started, when we have identified, when staff has identified a set of hospitals that, with the possible data exception that we've discussed around North Bay and maybe even Marshall, you know, are clear outliers, that the argument is quite strong, that affordability will be enhanced by lower targets here. And even if the lower targets are not perfect, you know, kind of the cost relativity approach makes sense, but, you know, there are potentially other approaches. It is a way of getting started in saying that we need to work on affordability. And I think I haven't seen an alternative that seems better at this point, although I'm sure we'll hear from the public and maybe hear some alternatives.
Sandra? David?
I would echo my colleagues' points. Methodologically, I know that we're not in a perfect place, but when you think about the significance of the crisis that we're facing in terms of hospital affordability, healthcare affordability, I think that this is a a great step in the right direction that we're taking. I'm sure that the office will look at further refinements for the methodology. The cliff effect is a clear issue. Early data versus bad data is an issue methodologically. I'm sure you've scrutinized that very carefully. But I think that this is a significant step in the right direction, and I think the office is to be commended for this progress.
Richard?
Thank you. I think, certainly this is sort of the front end that we're talking about, and I think having some guidance as to what we're going to be looking at the back end. So, from a policy consistency point of view, right? Obviously, different hospitals are going to be different, but that find some guidelines. We talked earlier. I want to put a pin back again about, is there some approach that will address the systems issue, right? So that we're not essentially destroying ecosystems or damaging ecosystems that allow people to have access to care in their communities, because they've picked a financing arrangement that now is causing problems for given the new structure we're opposing now as OCA. So I think that's something to look at the back end. And frankly, even when we set the initial cost target of 3.5%, I expect that even a lot of the hospitals that aren't on this category may have some challenges meeting that. So I think this back end conversation is going to be really important, right? Exactly what we're going to do when people miss target, whether it's 3.5 or 1.8. What are we going to do? What are we going to pose on people? Is going to be particularly important. And essentially, are we going to tell them how to run their hospitals or not? And if they still don't meet the target, then who's to blame?
Well, let me just say, I sort of agree with this notion that we need to get started. You've been meeting with hospitals, the hospitals that are in this really high cost outlier position. They should make a case for why they're, 942% higher than their average other hospitals, and we should try to understand that. I have a hunch that systemness is not the issue in these high outlier hospitals. That doesn't preclude our desire to understand that on a go-forward basis for the overall hospital spend targets. But for these outliers, I think we should meet with them, and we should try to, they should justify why they think that's appropriate. But I think we need to start with the methodology we have. I take Don's point really valid. If this data is correct on North Bay, we should bring North Bay in and ask them what they've done to start this kind of reduction in spend. And we should really think whether the policy should apply to them or not.
Thank you. Not seeing, please.
Just very quickly, I agree with my fellow board members. I think this is directionally correct, even if there will be adjustments as we learn more. I do also just want to say for the record that we have heard from patients and community members that they are needing immediate relief, and I think this is sort of the least we can do to start addressing the most egregious outliers. So I won't surprise anyone. I'd like to go further faster, but I do think that this is a reasonable step.
Thank you. Not seeing any other questions or comments from the board. I too want to just appreciate the staff for their continued effort on this and really trying to unpack again in that full context that I referenced earlier, and agree that this is clearly where we are, with some things to continue to learn along the way, and just appreciate the continued engagement that I know we'll have in just a moment here, as we're also calling for public comment to refine as we go forward. But just a critical and urgent need to move forward, and just again appreciate the staff's diligence on working through and unpacking and sharing this data, and formulaic methodologies with both words and pictures are always appreciated here too, as we're trying to think through how the targets are being set forward. With that, I will open it up for public comment.
We'll now take public comment on this item. Please step to the podium or raise your hand virtually. As a reminder, please limit your comments to this agenda item. We will have a general public comment period. We will start online. Chris Rosa, we see your hand raised. Go ahead. Chris, we can't hear you on this end. You might need to unmute on your end. All right, we will come back to Chris. We will go to the podium.
Hi, good afternoon. Anate Miller speaking on behalf of the California Association of Health Plans, also known as CAP, representing 41 Knox-Keene licensed health plans in California that collectively provide coverage to 28 million Californians. CAP supports OCA's goal to identify disproportionately high-cost hospitals in the greater context of the sector target discussion. In developing a methodology to measure these high-cost outliers, we agree in premise with OCA's recommendation to examine both unit price and relative price. Combining these measures takes into account several important factors that may otherwise be unaccounted for, and accurate data is critical to forming the full picture of hospital costs. Directionally, it makes sense for OCA to focus on identifying facilities that have consistently high costs across multiple measures to start with, and then have the flexibility to adopt a more granular approach in the future. CAP will submit further written comments in response to OCA's detailed recommendation, including the proposed sector target value and adjustment steps. Thank you very much.
Thank you. Going back virtually, Maya Schneider, please go ahead.
Good morning. My name is Maya Schneider. I'm the Executive Director of Business and Strategy for Marshall Medical Center. We are an independent nonprofit mini health system with a disproportionate share hospital located east of Sacramento. We agree that driving down the costs of healthcare is a worthy goal, but methodology needs to ensure you reach the desired outcome. It is premature to develop a roadmap at this point without ensuring the baseline methodologies are correct. Unfortunately, we believe the proposed methodology is flawed, and the likely outcome of using the proposed methods will be to reduce access to care. For example, your commercial reimbursement calculations do not consider the high cost of delivering care. As others in this meeting mentioned earlier, our expenses, including labor, materials, and supplies, have grown by double digits in the last 5 years, while our operating margin was a loss in that same period of time. We also worry that the proposed metrics do not take into account the specific nature of hospital expenses in California, including but not limited to the costs to comply with Senate Bill 1953, seismic, and the prohibition against the corporate practice of medicine, and other unique features of the California hospital landscape. We are very concerned that there is no control in your commercial reimbursement measure methodology for payer mix. As a disproportionate share hospital, our payer mix is 50% Medicare, 25% Medi-Cal, and those payers reimburse us roughly 70 cents on the dollar of the actual cost of care. We also provide inpatient and outpatient services in our hospital, yet you've carved out outpatient care. For these reasons and more, we commend you to the specific comments submitted by the California Hospital Association and urge the board to undertake more collaborative, fully engaged work with hospital stakeholders. To a comment made by one of your board members a few minutes ago, Marshall welcomes the opportunity to meet with you to discuss methodologies. We encourage you to take the time necessary to get this analytical framework correct to achieve the desired outcomes. Thank you for your time.
Thank you. We'll go to the podium and reminding folks to try and limit your comments to 2 minutes so we can hear from as many members of the public as possible. Go ahead. Turn the microphone on. Press it till it's green.
Mi nombre es Juana Maldonado de López. Estoy representando a mis compañeras de trabajo del Hyatt Monterrey. Tengo mi historia. Mi esposo se enfermó. Estuve pagando mucho en el hospital. Vino el COVID. Nos subieron la renta y, o sea, tuvimos un económico fuerte.
So hi everyone, my name is Juana. I'm here representing my coworkers as well from the the Hyatt Regency in Monterey. I wanted to share with you all a little bit of my story. My husband got sick and was hospitalized, and I was responsible for paying bills. We were not working at the time. This was during COVID, and I had over $9,000 to pay.
Sí, nos llegó el bill a casi $9,000. La aseguranza pagó más de $100,000 de un receso y total pagué pagos directos, duré 2 años.
You know, the cost of living increased, our rent increased, and on top of that, I had to worry about medical bills. I paid over 2 years, $9,000, and was paying directly.
Sí, no subieron la renta, no estuve trabajando, mi esposo tampoco. No, fue un stop, un paro económico.
Our rent was raised. I wasn't working. My husband wasn't working. We were stuck financially.
Gracias por explicarme. No speak English poquito, pero no puedo, no. Gracias.
I just wanted to share with you all and thank you all for listening. You know, I don't speak English that well, but I guess that's my story.
Thank you. Looking virtually, Connie, please go ahead.
Hi, good morning, members. Connie Delgado on behalf of the District Hospital Leadership Forum. California's 33 district and municipal hospitals are independent public hospitals. 2/3 of them are rural and 18 have critical access designation. With publicly elected boards, they are proud to be local governments responsible for providing health care needs for the communities. While district hospitals only represent 8% of the hospitals statewide, more than 30% of our hospitals received distress hospital loans and qualified for more than 50% of the funding. Due to financial difficulties district hospitals have faced over the years, California has seen more district hospitals close their doors, file bankruptcy, or get acquired by larger health systems as their only option for survival. 20 years ago, there were 56 independent public district hospitals. Today, we're down to 33 and likely 32 or 31 at the year end. By the year end, district hospitals are concerned with the accelerated timeframe after last month's approval of hospital sector target. The proposed actions unfairly target specific hospitals, including 2 district hospitals. Like the concerns flagged by our UC public hospital colleagues, the high cost methodology does not accurately account for the uniqueness of public hospital financing. Specifically, the fact that most of our Medi-Cal revenue is self-financed through intergovernmental transfers, IGTs, where we act on behalf of the state to support our payments, and like private hospitals, which participate in tax, we serve as a governmental entity supporting most of our payments to draw down federal funding. Unfortunately, HCI hospital reporting does not accurately reflect these public hospital financing nuances, which, if not adjusted for, skew the results in inflating hospital district revenues. In addition to the public financing challenges, the methodology does not accurately account for the allocation of inpatient versus outpatient net patient revenue. District hospitals tend to be sole community providers of healthcare and provide a significant portion of services in the outpatient setting. The best illustrated by the fact one of the district hospitals identified on your list as high cost by OCA staff closed with their fiscal year end 23-24 with -2% operating margin and currently sits with 17 days cash on hand. We urge OCA to treat all public hospitals, districts, UCs, and counties the same. Thank you.
Thank you. Back to the podium.
Mi nombre es María Argüelles. Vengo acá también de allá del Hayas de Monterrey. Yo contando con la voluntad de Dios no he ido al hospital, ¿verdad? Pero sí me da miedo que algún día yo y mi esposo caigamos al hospital porque los dos somos diabéticos.
So hi everyone, my name is Maria. I'm also coming from the Monterey Hyatt Regency. You know, I thank God every day that I haven't gotten sick, and I worry every day about getting sick and being hospitalized, as both my husband and I are diabetics.
Y da miedo pues de que vayamos al hospital y que nos llegue el gran bill, que no tengamos cómo pagarlo, ¿verdad? Y luego aparte de eso nos afectó de que nos quitaron dos aumentos en el trabajo porque nos quitaron para cubrir la aseguranza.
It's something that we worry about every day about, being hospitalized and then having to worry about the bill afterwards. It also isn't helpful that everything is really expensive, and we lost 2 raises because we had to cover the cost of our healthcare as part of our union.
Eso es todo. Muchas gracias por escucharnos.
So, thank you all. Thank you for listening to us and for your work.
Thank you. Looking back online, Ellie?
Could you hear me?
Yes.
Fantastic. Ellie Mainshine on behalf of Sharp Healthcare. We want to thank OCA staff for meeting with us earlier this month and for the opportunity to comment here today. Sharp remains very concerned about OCA's failure to recognize the difference between traditional Medicare fee-for-service and capitated Medicare Advantage reimbursements, both in terms of their impact on cost calculations as well as the impacts on patient utilization and outcomes driven by these different methodological reimbursements. Healthcare cost trends are tied to both individual unit cost or price and utilization trends. And utilization trends are driven in large part by fee-for-service reimbursement methodology. Capitation reimbursement help solve for the fee-for-service incentive to do more rather than do what's best in patient care by aligning provider and patient incentives. In fact, one of our affiliated physician groups, Sharp Reeve-Steele Medical Group, was invited to and did present to the OCA Advisory Committee last year about Sharp's capitated model of care as an example of a successful alternative payment model that leads to the outcomes that OCA seeks, high-quality care at a lower cost. The Sharp Reeve-Steele presentation was then shared with this board at the January 2024 board meeting under the heading Examples of Cost-Reducing Strategies Employed by Elevance and Sharp Reeve-Steele. Population health is core to Sharp's approach to care and its reimbursement structure for more than 20 years. And this is through our heavily capitated model for both physician and hospital reimbursement, which accounts for approximately 26% of Sharp hospital revenues. Sharp's use of capitation is central to our ability to provide high-quality care at a low cost to our patients across the San Diego region. As we shared with OCA staff, the variability in reimbursements and revenue allocation under capitation, aka Medicare Advantage, undermines the utility of using total Medicare as the standard benchmark. There is no standard methodology for how systems capitated revenue associate capitated revenue from Medicare Advantage to their hospitals, and combining these Medicare reimbursements skews the data in the commercial to Medicare payment to ratio calculation. To address this variability and avoid penalizing systems that utilize capitation to drive high quality and cost efficient care, Sharp again recommends using traditional fee-for-service as the base for Medicare-based calculations, which modifies and normalizes for capitated reimbursements. We urge OCA to recognize these separate, distinct methodologies and their impacts on cost and outcomes to care.
Thank you. To the podium.
Hello, good afternoon. My name is Cynthia Corres, and thank you for all the work that you guys do. I'm a community leader of the city of Seaside, California, and also I'm a community health worker. And I'm here to advocate reducing the high cost of the service that hospitals provide. Wherever it will perform, when you go to the hospital, for example, to do a blood test, a urine, it's very expensive, to be honest. Personally, I'm afraid to go to the emergency room, first of all, because I don't have any health insurance. And secondly, because the high cost and how they charge. For example, I took my daughter without insurance, and to be on the room for 2 hours, it was more than $3,000. So I really hope I don't spend the night there because it's very expensive. And community, the community of Seaside who use community hospital, I talked to them and they say the cost is really expensive to go there and to have an emergency. And also we have like Doctors on Duty and Mogo, but it's also owned by these hospitals, right? By community hospitals. So we don't have where to go. If I had an emergency, where do I go? Community hospital, Mogo, Doctors on Duty, Salinas Valley. So we don't have anything to go like more affordable. So we need affordable care. And also, I have been learned that the prices of since I follow this work that you guys do, I'm very surprised the cost of these hospitals has versus the New York or Chicago. So what we want as a community and also as a person, it's an action. It's an action, please, a reliable action for all the residents and also for the high cost and the living expenses. Thank you, and thank you for all the work that you guys do.
Thank you. Looking back virtually, noting for the record, we have about 132 virtual attendees, and right now 6 hands raised, reminding people to limit their comments to 2 minutes so we can hear from everybody. We will go to Adam.
Great, thank you. This is Adam Zarin, the Director of State Government Affairs for the Leukemia and Lymphoma Society. We're a national nonprofit trying to cure blood cancer and improve the quality of life for patients and their families. We thank you again for this board's continued focus on healthcare costs, especially those at hospitals, and we continue to encourage the board to do this work. You know, as I've mentioned before this body, many Americans, including Californians, are avoiding getting medical care or cutting back on medicine because of high costs. Again, in fact, 4 out of 10 cancer patients won't start treatment when they have high out-of-pocket costs. Some will borrow money from friends or families, but most will end up with medical debt. High healthcare costs, especially from hospitals, are turning into medical debt, and it's becoming a common reality for Californians. The numbers tell a sobering story, but so do the experiences of some of our patients, like Lori in Los Angeles. Every month, she receives an infusion to help her immune system after 12 years of intense cancer treatment. Her insurance is billed $10,000 each month for these life-saving infusions. This was after she received CAR-T treatment at her local hospital to save her life. This is an incredibly expensive treatment, sometimes in the millions of dollars. She's also recently had a hip surgery. Her insurance was billed $16,000 for the surgery and an anesthesia, and her overnight cost $23,000. She's lucky to have comprehensive insurance that protects her from these huge out-of-pocket costs, but these costs aggregated across the population will make healthcare more expensive for everyone. You know, many patients are not as fortunate as Lori, and most, again, will take on debt or skip treatment altogether. So we encourage you to continue to take decisive action to protect patients from the crushing medical debt that someone will face, and then ensure that no one has to choose between health and financial stability. Thank you so much.
Thank you. Back to the podium.
Good morning. My name is Vicky Silva. I'm also here from the Hyatt Regency of Monterey. And we have lost 2 wages. I'm now out of my house. I'm renting a room. I'm on liver support. So that $1.25 would have done a lot for me. I lost my brother. Now my doctor to tell me that my liver is crashing. I'm only 51 years old and having to worry. I'm working 6 days this week. The only day I have off, I'm here to speak for the people that couldn't make the drive here. But, you know, I'm afraid to go to the hospital. I just don't want to go. I'd rather sit home and throw up and throw up and throw up and cry alone in a dark room because I don't want that hospital bill. And I know that you guys are working hard to get a solution, and I highly appreciate that you guys came out to our area. That's very much appreciated. But I just don't know. You know, people, like he said, people shouldn't have to pick between bills and health. If I'm not healthy, I can't go to work. So, you know, now that I'm on a strict diet and on liver support, I have daughters, I have a granddaughter, and I want to know that if one day I'm not feeling good, I don't have any family here anymore. My brother passed away last year in March, and I think I told you guys that last time I came. I'm alone. I'm completely alone. And I'm always struggling, just thinking, crying. It stresses me out. I can't sleep. I wake up vomiting, and it's not, I go to work vomiting. I vomit at work. I've gone in trouble at work because I was vomiting. But that's not something you can control. I mean, my health is my health, and I want to be healthy, and I want to be able to know that I can go to the hospital in my area, that I don't have to travel 2 hours or 3. I could be dead by the time I get there. On the way here, I threw up. And it's only 2.5 hours away, and I feel bad for the people that I drove here with because they had to see it. But it is what I go through every day. And when I throw up at work, I go to my truck because I know that when I take my medication, I'm going to throw up. And I don't want people seeing it. Someone asked me at work one day, Vicky, how come you move your truck from location to location? I said, because I throw up. I open the door and I throw up, and I don't want to step in my own vomit. And I know
2
that's not
minutes.
okay. Thank you. Thank you so much for your hard work.
Thank you. Going virtually, Kevin. Kevin, you're unmuted on our end. You might need to unmute on yours. Kevin Causey. All right, Kevin, we will come back around to you. Back to the podium.
Good afternoon. My name is Esteban Rodriguez. I live in Monterey County. I believe this is maybe my 4th time speaking here at OCA, so familiar faces. Hi, everyone. I shared my personal experience before of the overwhelming hospital bill costs that I've received. Like many in my community, I struggle with the high cost of care, only to find out that the hospitals in our area, in Monterey County, are among the most expensive in the entire state. The spending cap may seem like a progress, but when prices are already inflated and already high, even a small increase keeps healthcare out of reach of many families in my community. We are not starting at a fair baseline. We're already paying too much. A cap on spending growth doesn't help if we're still drowning under unaffordable costs. I urge you to lower the cap for Monterey County specifically under 1%, ideally 0.1%. At minimum, there needs to be a stronger effort to bring prices down, not just slow increase. People in Monterey County and across California deserve healthcare that is in fact affordable. Right now, we insured patients are avoiding care, as you heard, because they know they can't afford out-of-pocket costs. Thank you for your work. We do need bold action, not just limits on how much prices can continue to rise. Please consider a lower cap that actually moves us forward towards a fair, accessible, truly affordable, and reasonable healthcare pricing. Thank you.
Thank you. Looking back virtually, noting, Kevin, I see that you put your hand down, so we will move to Kimberly Hartz. Please go ahead.
You hear me?
Yes, go ahead.
Thank you for the opportunity to speak before this board. I am Kimberly Hartz, Chief Executive Officer of Washington Health, a healthcare district located in Fremont, serving Southern Alameda County and listed on your list of 11 hospitals. We have a 415-bed licensed hospital that has a full range of inpatient and also a full range of outpatient services that are not taken into account in your methodology. As a healthcare district, Washington Health is a non-designated public health system. We were founded in 1948 by the residents of South County because they wanted local health care. We have a publicly elected board of directors. We are basically a public governmental entity responsible for providing for the healthcare needs of our community. Our payer mix is over 75% governmental. We play an essential role in the Medi-Cal program and provide comprehensive healthcare services to our low-income community residents, including being a level 2 trauma center, taking care of anyone that walks through our door. As the OCA staff analysis showed at your January board meeting, our operating margin during the 2018 to 2022 period of time was 0%. More specifically, between 2019 and 2022, our consolidated net income was negative. Nobody is happy about the cost of healthcare, so we understand your goal of reducing the cost burden for consumers. But as a standalone public healthcare district hospital with long-standing community support, we have serious concerns about being subjected to a reduced cost growth target. There will be unintended consequences that will impact our ability to provide care to those who need it most in our community. I believe we have unique circumstances that have not been adequately addressed in the methodology used to create this list. There are additional operating metrics that must be taken into account given our mission to serve our community. We look forward to the opportunity to discuss this situation with the OCA staff in the near future. Thank you for your time and consideration.
Thank you. To the podium.
Thank you and good afternoon. My name is Fred Noteware and I'm here representing Stanford Healthcare. Stanford is deeply concerned that the target means it will be forced to reduce the care it provides. As a predominantly tertiary and quaternary care facility, Stanford Healthcare has one of the highest case mix indexes in the country because of specialization in complex diseases and complications. Adherence to an even lower spending target would effectively prevent Stanford from providing life-saving care our practitioners are trained to provide, including, but not limited to, rough oncology cases, critical transplantation procedures, advanced cardiothoracic surgeries, and level 1 trauma care. We also want to mention the higher cost of living in Northern California, especially Silicon Valley, and how Stanford pays a living wage and benefits takes all patients, regardless of their ability to pay. Stanford is an academic medical center, a teaching hospital. There are naturally higher costs given the need for ongoing medical research and physician education. Thank you.
Thank you. Looking back virtually, going back to Kevin Causey, can you unmute on your end? All right, Kevin, we can't hear you on this end. We will try and come back around. Travis West, we'll have you. Travis, can you go ahead?
Yeah, thank you. Travis West, Regulatory Policy Specialist with California Nurses Association. We thank OCA staff for their work in putting together this recommendation. We support the staff's recommendations for identifying disproportionately high-cost hospitals, determining sector target values, and lowering the target growth rate for disproportionately high-cost hospitals. And we encourage OCA to adopt, implement, and begin enforcing adjusted targets as soon as possible. As discussed in today's presentation, even with the lower targets contemplated by the staff's proposal, it will take approximately 20 years for high-cost hospitals to come in line with the rest of the industry. As nurses see firsthand on a daily basis, patients need relief from high costs now. The enforcement of spending targets should not be delayed further. Thank you.
Thank you. To the podium.
A lot of my comments are going to echo what you just heard. My name is Katie Bassler. I'm the president of Salinas Valley Federation of Teachers, Monterey County. My comments are in support of the recommendations to adjust the target for the top repeatedly disproportionately high cost outliers, specifically those in Monterey County, which is what we're experiencing. If I understand correctly, your model, which was fun to look at, within 22 years, I would be 77, just so that we have some perspective on this. It would take that long for these high-cost hospitals to be in line with those that are around the 80 percentile. And if you lower that target to 1.8, it will take 20 years. Well, now I'm 75. I hope I'm still here. There are no guarantees, but I'm not here today for me. I'm here for the workers of Monterey County who have suffered for years with these high-cost hospital systems. We support the selection of hospitals that have been outliers for 3 or more years. We'll look at the data. We agree that maybe there should be an annual review to see if there are changes. The adjusted percentages would slow the rate. We are already at too high of a rate. It makes me so sad to hear the hospitality workers speak of their inability to access health care as educators. We are just skipping it because we can't afford the co-insurance. Board, thank you for your continued work. Thank you for giving us this space to express our concerns. We really need this change now. Thank you.
Thank you. Looking back virtually, noting for the record, we have about 126 virtual attendees with 5 hands raised. We're going to go to a caller that is dialing in with the last 2 digits, 83. Caller.
Hi, this is Chris Rosa. Can you hear me?
Yes, go ahead.
Okay, great. Sorry, I couldn't get off mute. I don't know what was wrong with my microphone, but Chris Rosa on behalf of Silicon Valley Leadership Group. SVLG is deeply concerned with HOKA's proposed cost growth targets. Particularly in the Bay Area, labor costs and other structural expenses tend to be higher than in other regions. SVLG encourages the HOKA board to take a different, better data-driven, sustainable approach that reflects these regional cost differences. The regional cost differences are really important to look at. We can look at these regional cost differences while still supporting the long-term stability of the healthcare system. As currently outlined, aspects of HOKA's approach, including its designations of high-cost hospitals and differentiated cost growth targets, will have unintended consequences that impact care. Key metrics used to determine designations such as inpatient revenue per discharge, operating margins, and third-party to Medicare cost ratios often yield conflicting results, inadvertently categorizing hospitals in high-cost regions as inefficient. However, these designations do not fully account for structural economic factors like higher wages, real estate costs, and compliance with state-mandated regulations that continue to drive expenses. With a slight modification in your methodology, HOKA can better account for these regional challenges that hospitals face and avoid imposing undue financial strain on institutions that are already under significant pressure. As currently proposed, targeting high-cost regions like the Bay Area could mean, for example, number one, us needing to reevaluate planned service expansions and community health investments due to high cost of necessary technology and real estate, both essential for delivering high-quality health care. Secondly, disruptions or reductions in service lines, including those already facing financial challenges, such as behavioral health, geriatrics, and certain community health programs. And third, challenges in meeting California's 2030 hospital seismic retrofitting requirements due to financial restraints. We ask that HOKA please reevaluate your methodology for identifying high-cost hospitals by incorporating a broader set of financial and operational metrics that capture the economic landscape of different regions more accurately. Thank you very much. We appreciate your consideration.
Thank you. Back to the room.
Hello, I'm Ivana Krajinovic with Unite Here Health. Also want to thank the board for its work and support the recommendation on the outliers, although we would also prefer something closer to a 0 or 0.1% target. But we realize that this spotlight and the timeline that you're working under are really important because in the end, these hospitals can on their own decide to bring down these prices. You shouldn't have to be setting these caps to do so. I really want you to encourage you to hold the line over the next couple of months because you're going to get lobbied hard and you're already getting lobbied hard to change these targets. So, you know, for instance, this issue about having to subsidize other things in the community, what Dr. Tan calls playing a role in the ecosystem can also look to us like protecting and extending a monopoly, especially in Monterey County. And we don't feel as commercial payers that we should have to underwrite those sorts of efforts. If they want to subsidize other parts of the business outside of the hospital, they should find efficiencies to do that or cut waste. That's where that should come from, not just automatically charging more to commercial payers. I also want to address the concerns of Stanford and other academic medical systems with an example. Last year, we were given a double-digit increase from Kaiser, which was really unexpected. And when we drilled down, we realized that there was one claim that was out of network and was treated at Stanford. We paid, the bill for this claim was $15 million. It was a pediatric cancer case. We ended up paying almost $10 million on this one case for less than a year of care. And in fact, $8.3 million of this claim came in 1 month alone. I don't even know how you spend $8 million in 1 month on one case. We ended up paying Stanford on that claim almost $9.5 million. The remaining $438,000 would have been enough on its own just to constitute a high cost claim, the money that we paid Kaiser. The child in this case unfortunately died, and workers across the country ended up underwriting this claim. It was so large. Because of this double-digit increase, we had to raise rates so that workers in Baltimore, low-wage food service workers, were helping to pay this claim. Academic medical centers don't want any constraints, and I don't think they should get a pass. So we really hope you can continue to hold the line and keep Stanford in the outlier category as well. Thank you.
Thank you. Looking virtually, Ben Eichert, go ahead.
Thank you very much, members of the board. Benjamin Eichert with the National Union of Healthcare Workers. Just want to reiterate that every year, high hospital costs push up the costs of providing benefits to the workers in our union. And that means that there's less and less available to address wage and working condition concerns when we negotiate with employers. We think it's imperative that these costs are reined in beginning now. We appreciate the work that OCA is doing. We support the recommendation, and we urge you to enact reforms promptly and without further delay. Thank you.
Thank you. Back to the podium.
Ben Johnson with the California Hospital Association. California's hospitals oppose the rush creation of hospital sector targets, coming years before statutory deadlines, before OCA has completed or begun work on key deliverables, including relating to core functions of the office and how to measure hospital spending itself. This rush to adopt sector targets prior to undertaking proper due diligence has led to serious flaws in OCA's methodologies for identifying high-cost hospitals, as highlighted by the example of North Bay, as well as with the target values being proposed. As our letter demonstrates, the commercial reimbursement measure penalizes hospitals in high-cost areas and those with more challenging payer mixes. The commercial to Medicare payment to cost ratio is similarly flawed, fully dependent on the soundness of Medicare payment policies that over time have become increasingly divorced from the realities of on-the-ground hospital financing. And these flaws in Medicare payment policies often flow, as discussed, from budget neutrality requirements for Medicare hospital payments that makes them inherently redistributive, so that policies that boost Medicare payments for some hospitals take away funding for other hospitals, increasing some hospitals' shortfalls, increasing others. A key example also discussed was graduate medical education funding from Medicare. And when we look at the shortfall for just one hospital, it ultimately increases their commercial to Medicare payment to cost ratio by an estimated 25 percentage points, that measure of relative cost that OCA is using. Ultimately, the commercial to Medicare payment to cost ratio primarily punishes hospitals with large Medicare shortfalls resulting from flaws in Medicare payment policies. And this can be most clearly seen in the addition of Barton Memorial on the list of high-cost hospitals, which has a Medicare payment to cost ratio of just 29%, 50 percentage points less than the average statewide. And it causes it to catapult onto OCA's list of high-cost hospitals. Even more concerning, the spending targets proposed would inevitably endanger access and patient care. The targets of 1.7 to 1.8% or so are 35% lower than inflation for all goods and services, and 70 to 80% lower than recent growth in the major inputs to hospital care, including labor, drugs, supplies, and other key factors. And so the subject hospitals would unavoidably have to shed staff, cut essential service lines, curtail investments intended to improve quality, access, and equity, consequences that are antithetical to the spirit and letter of this office and would be exacerbated by parallel efforts at the federal level to destabilize California's healthcare system. So California's hospitals recommend an alternative path. We recommend that you follow a sound and deliberative process, gather and look at comprehensive data, take stock of pending federal actions to radically cut healthcare spending, Evaluate and learn before making decisions that could harm the lives and livelihoods of millions of Californians, and encourage cross-sector collaboration toward the shared goals of creating a high-quality and affordable healthcare system. Thank you.
Thank you. Looking back virtually, noting for the record that we have about 121 virtual attendees with 3 hands raised, and reminding people to limit their comments to 2 minutes so that we can hear from everybody. We will go to Francisco. Francisco, you're unmuted on our end. You might need to unmute on yours. We will.
Can you hear me?
Yes, we can hear you now.
Great, thank you. Francisco Rodriguez with the Monterey Bay Central Labor Council. We are we have 80 affiliates across, over 80 affiliates across the Monterey Bay region, representing about 37,000 union members. I just want to make 3 points. I know this is getting long, but number one, I just want to say, please don't delay in implementing these limits. You need to take action now. We do support the recommendations by staff, although we were hoping for a lower limit. And the prior speaker mentioned that this was going to affect patients. Well, already people are hurting their livelihoods and their lives. So you need to act as quickly as possible. And my last point here is that couple meetings, or at the last meeting, it was mentioned that only 2 unions were concerned with this. That is not the case. Many unions in our healthcare committee have come forth, including NUHW, CSEA, CTA chapters, carpenters, all have come in and asked us to work with them to help create these limits on healthcare. So again, thank you to the staff and to the board for taking this on, and hope that we can support the workers that came here to address you. Thank you.
Thank you. Back to the podium.
Thank you. Beth Capel on behalf of Health Access California. The work of this body was delayed for years by the obstinate opposition of the hospitals to getting to what has now become the Office of Healthcare Affordability. In fact, these delays now amount to almost a decade. So there has been plenty of delay. You have heard more compelling testimony than I can ever give from some real people who face horrible situations because of the costs they suffer from these very high-cost hospitals. I want to point out a couple of things that are in your presentation, just so to focus us back on the work at hand for these really high-cost hospitals. Comparable hospitals charge on average $20,000. These high-cost hospitals charge $40,000. We have comparable hospitals where the mean is about 200% of Medicare, and high-cost hospitals that are about twice that much, or even more, 5, 6, 7, 8 times Medicare. That's what we're discussing here today, is these very high-cost hospitals. In response to the observation by Dr. Pan about the bimodal distribution on the Medicare rates, we noticed it as well. We recall from the earlier work by Kronik about healthcare costs in California that distribution around 100% of Medicare is largely Southern California hospitals, and we suspect that those around 200% of Medicare are largely Northern California hospitals, driven by the run-up in costs caused by Sutter. So that's why we're here today. We support the staff recommendation. We wish it went further. We wish it went faster. from our perspective, we've already waited a long time, and I think you've heard from
2 minutes.
Real people today who've made that case in a much more compelling way than I can. Thank you.
Thank you. Looking back virtually, we're going to go to a caller that had their hand raised with the last digits 84. Okay. Is this someone dialing in with the last two digits 84?
Hi, can you hear me?
Yes, we can hear you now. Go ahead.
Oh, good. Thank you so much. And this is Kevin Causey calling from Montage Health and the Community Hospital, Monterey Peninsula. Forgive my technology woes here. We continue to be concerned by the actions taken under the aegis of OCA. As you know, your duty is to ensure that all Californians have access to affordable, equitable, high quality, and universal health care. But the methods demonstrate an alarming lack of recognition of the economic realities of an integrated healthcare system. We urge you to focus on system margins rather than hospital margins to identify outliers, or barring that, return to an average net revenue per CMA analysis to normalize for a wide regional payer mix variations. We are a great example. When you look at our system margin in 2024, we had a 1.1% net margin. Further, commercial to Medicare ratios are a profoundly misleading metric for determining high-cost outliers because Medicare reimbursement varies dramatically by institution type. For example, higher Medicare reimbursement at academic medical centers drives their commercial to Medicare ratios down, and usually they're receiving higher commercial reimbursements than other hospitals. The result is a higher commercial reimbursement, higher Medicare reimbursement, and a lower ratio. As we've stated to this board and HCI leadership in the past, this definition of a hospital sector is wholly premature, coming years before statutory deadlines, and is absent of a large measure of due diligence. The rush to action has the same sort of ready, shoot, aim feel that we're seeing coming out of Washington, D.C. in recent weeks. And any methodology that singles out 11 hospitals out of California's more than 450 does not bend the cost curve, but serves other agendas, as has been stated for months now. These actions have unintended but completely predictable deleterious effects on access to health care. When we talk about for Montage Health, the biggest cost outlier are physicians and physician practices that lose money because we take every single person that walks in the front door. We're not talking about inexpensive random wellness programs when we talk about the community health that we provide. It's not too late to change direction, correct a process that will determine the future of millions of Californians. Barring a change of direction, you will be responsible for the closure of services, staff layoffs, and the communities affected by these arbitrary and capricious actions. Thank you for your time.
Thank you. Back to the podium.
And good afternoon. My name is Clint Purvance. I'm an emergency physician, a practitioner that's worked in the safety net hospitals and ERs in California beginning in 1999. I'm also the president and CEO of the Barton Healthcare System. And while that occupies most of my time these days, we've built a system around principles that care for everybody in our community. Barton Health is located in South Lake Tahoe. Many of you have traveled there. Probably couldn't find our hospital on a map because it's quiet and it's hidden in our community. We're a rural hospital. We found ourselves surprised last Thursday that we were on this list. Previously, we were not until last week. And while we've not yet had any communications from staff, and I look forward to that, I'm grateful that you as a board are seeking input from health systems to try to understand why we're on the list and what that means for our communities and what it may mean for the safety net hospital system that we've created to serve our community first and foremost. Barton is unique in that we're a bi-state health system. If you've been to Lake Tahoe, you know that we have a state line that runs through the center of our town. That changes the dynamics of those that we care for. We care for Californians, we care for Nevadans. We have infrastructure on both sides of the state line. In fact, we have a critical access hospital that we also own in Nevada. And our physicians that practice with the health system work throughout California and Nevada. The physicians in California have struggled to have private independent practices over the last decade. It's gotten significantly worse. Many of my colleagues that I've worked with for 2+ decades have come to me and said, Clint, if you can't support us as a physician network, we can't provide services in the community. We go broke without your help. And so we've set a system up where our physicians and our providers care for everybody, regardless of ability to pay. Some of that care happens in rural health clinics, but most of it happens in our ambulatory footprint where our practitioners see patients from across the state.
2 minutes.
Thank you. I would just say that as a physician, we have all unique characteristics, and I always want to take care of a patient and understand your unique qualities in that personalized medicine that will help me diagnose, treat, and ultimately help you find a great outcome. I would ask for the same consideration as a health system, that you take a look and we work with your staff so that we can better understand the unique characteristics of our bi-state health system and how it functions. And does it meet the financial data that is comparable and the targets that are being proposed? I thank you for your time and consideration.
Thank you. Going virtually, Steve, go ahead. Steve, you're unmuted on our end. Can you unmute on yours?
Sorry about that.
Yes,
Thank
I
you.
can hear you.
Okay. Steve McDougall with CFT, a union of educators and classified professionals. I'd like to thank the board for their work and certainly staff for theirs as well. CFT supports the recommendations for the outlier hospitals, providers. The Montgomery County vicinity, according to the data in this meeting, is 84% above the national median for hospital provider pricing. And there's plenty of past data out there that supports that, no matter how much one wants to argue that data in the slide today. Just look at the covered California ratings for our region. We're the tops there too. We're second in the nation to the San Jose metro area. Claims of bad data are baseless when no matter how one looks at the hospital pricing data, a number of highly priced facilities remain in the top tier for pricing. Poo-pooing the professional staffers at OCA's research falls on deaf ears when one understands what the problem is. Runaway train pricing for a few hospital providers. Attacking workers and their families is never a good look and will be remembered. At some point, the chambers of commerce, business leaders will be awakened to what's happening in markets like Monterey County. There will be no amount of spinning and deflecting that will save the reputations of these highly priced facilities, some of which can't get a CMS rating above 3 stars. So it doesn't mean quality equals price. Continuing to squeeze workers and their families while making threats versus the state of California with tort claims, while having grossly inflated reserves, some with over $1 billion, will only lead to a lack of confidence in these hospital providers moving forward into the future. Thank you for your time. Thank you for your work. Hopefully it's time for lunch. I don't know who's up in the room there though.
Thank you. Going back to the podium.
Hello, my name is Carla Adams. I'm the Chief Nurse Officer at Barton Health. I have over 35 years of nursing experience, and my passion is to serve our community in their healing process and bring the best out in others. Who are we at Barton Health? Barton Health is a non-for-profit hospital. We have 63 acute care beds. We also have a long-term care facility, which is 48 beds. Our long-term care facility is a 5-star facility. We serve 95% Medi-Cal residents. We have a common goal in providing affordable access to high-quality care. We're located in South Lake Tahoe. We serve a tourist population, and we have seasonal peaks and lows that serves our hospital. 40% of our ED visits are tourism, 50% of our inpatient population, tourism. Today, our census fluctuates between 15 and 30, low census. As a small rural hospital with fixed overhead costs, lacking the large volumes that typically reduce the operational costs, it dramatically affects us. Some of the unique services that we have at Barton Health, we have OB and labor and delivery, and for a rural area, that's pretty good. We have a level 1 nursery. We also have pediatrics, another specialty that is unique for a mountainous area. We don't want to force families off the mountain to provide health care. We have a level 3 trauma center and have an intensivist program for our ICU.
2 minutes.
Also an expense. Barton Health offers orthopedic care. We offer nursing care that has dramatically increased cost over the last several years, and we support that. We're looking for community expansion, and we just want to say thank you to OSHA. Please support these small rural hospitals as we strive to provide consistently exceptional care to those that we serve. Thank you.
Thank you. Looking virtually, noting we've got about 112 attendees, seeing no virtual hands raised, going back to the podium.
Hi, my name is Kelly Niger. I'm the CFO at Barton Healthcare System, also known as Barton Memorial Hospital. I've been in healthcare finance throughout my career at Barton. Prior to that, I was in outside public accounting. I am born and raised in South Lake Tahoe. In fact, I was born at this hospital. And I can say that my parents, especially my mother, was very grateful that that hospital was there because I was almost born in the ED bay. So, that's a little bit history on me. I was surprised when I learned yesterday morning that Barton was added to this list, and the board meeting is today. I haven't had an opportunity to meet with OCA to understand the data that was the determining factor for us to be on this list. So as you can imagine, I probably spent several hours last night digging into the annual financial disclosure reports and trying to figure out how can this be, especially looking at the commercial to Medicare to cost report ratio. I can't reconcile it. I'm hoping that I have the opportunity to work with this team to validate that data, but I can tell you right now, I don't think it's right. I looked at our commercial reimbursement rates over the past several years. They're fairly flat. But I did notice one of the years the Medicare dropped more than 10%. That could be driving that ratio to look so high, but to me, it doesn't look accurate. It's not consistent with any other reporting that we do. So I am hoping that this body will allow Barton the chance to meet with you so we can fully understand it, and then also give you feedback on what these spending targets would do to our hospital and to our community. As described before, Barton is an independent sole community hospital. Our mission and our goals is to stay that way in our South Lake Tahoe community, not be absorbed by a larger system or worse, close. We want to keep healthcare local.
2 minutes.
Now, our average daily census, even though we're a 63 acute care bed, as our CNO was talking about, our average daily census drops quite a bit. In fact, we're typically below 18 when you look at it on an annual basis. One might wonder, then why aren't you a critical access hospital? Well, we looked at that. We looked at that over the past 2 years when we had operating losses, actually over the past 3 years since COVID. We looked to convert. We did the math and we said, maybe we can do it. Once we hit over that 25 bed threshold, we're just going to have to ship people out far away over the mountains to Reno or to Sacramento. But the truth is, if we did convert to a CAW, that cost would be borne on the Medicare beneficiaries. And yeah, that ratio would be smaller, but the Medicare folks would be paying that cost. We couldn't do it. And I just wanted to share our payer mix. 75% of our payer mix does not cover our cost. 60% of that payer mix are government payers. The rest are workers' comp. We don't talk about that. Self-pay and things like that. So I just want to thank this body for allowing us to comment, and I hope to hear from you soon. Thank you.
Thank you. Going virtually to Raymond. Raymond, we see your hand raised. You are unmuted on our end. You need to unmute on yours. In the top right hand of the screen, you should see a little speaker. It says mic. You'll need to click on that.
Okay, can you hear me now?
Yes, we can. Go ahead.
Thank you so much. My name is Buddy Renzulo, and I am a labor relations representative for the California School Employees Association. I represent classified employees in the school districts that utilize healthcare facilities and hospitals in the Salinas, Monterey, and Santa Cruz areas. Our employees are the lowest paid workers in your public schools. And one of the situations that we find ourselves in is that more often than not, when we're at the bargaining table, school districts often lump healthcare in with salary increases in what they call a total compensation package. And what this does is it assumes that all classified school workers have access to a district-sponsored healthcare, but in reality, a huge majority of our employees do not qualify for district-sponsored healthcare because they are not allowed to work for more than 4 hours a day. In these times of very low to no cost of living adjustment increases, the school districts might offer a total compensation package of, say, a 2% increase. And this usually will force the bargaining teams to split the offer by taking like 1% on salary and the other 1% on the increase to the unit's healthcare caps. But what does this happen? What happens is that to the employees who do not or cannot take the district's offered healthcare, they do not get any additional benefit on the healthcare that's offered in the district. Again, these are the lowest paid employees in your schools. And so they depend on organizations such as OCA to assist with the regulation of the healthcare in our facilities. We do appreciate that the board came down to see us in Monterey area, and that was fantastic because we know that you were able to hear so many compelling stories from our workers, not only in the schools, but in the surrounding labor organizations, as well as folks in the community. We completely echo the need for urgent reforms and no more delays, and we support the recommendations of staff. And again, we appreciate the work that OCA is doing. Thank you so much.
Thank you. Looking back to the podium.
Hi, my name is Kylie Labrato, and I'm here in support of Barton Health. I'm a working mom of 3 and the primary income earner in my family, and I struggle to make it financially in our area. I moved here from Denver, where we had access to a robust and urban healthcare system, to South Lake Tahoe, where there's a much smaller rural healthcare system. My children were 1, 3, and 5 when we relocated, and access to care prior to relocation was never a concern or even on my radar. I was reassured when I moved here knowing that the Barton healthcare system reaches all of my needs, from pediatrics, OB, and women's care to the specialists that see me and my kids, regardless of our ability to pay. And there's a generous charity care policy. I can't imagine Barton healthcare system not being in our area. I need the local services as we live on a mountain. I don't have the ability to take a day off work and pull kids out of school to travel to Sacramento or Reno for care. The time and loss of money are too great. I ask you to please don't make an uninformed decision that could limit the services that Barton provides to me and my family. I have spent the better part of a decade working in the fire service as a volunteer firefighter, EMT, and administrator. I have seen firsthand the experience that Barton takes and the care it takes for its constituents and visitors alike. Seeing and hearing stories of the care that they provide to residents and visitors is profound. Barton takes care of the local fire and police and the people that they serve and protect, as well as providing free health fairs, community sponsors for students in sports, a food network to support those with food insecurities, support for local transit for patients without cars or money for transportation. Barton is much more than just a hospital to our community. They care for us, provide the best doctors and nurses in the region. I don't want to go anywhere else for healthcare, and neither do my friends or family. We can't afford to travel for healthcare. We need our local system. Thank you.
Thank you. That concludes public comment on this item.
Thank you very much, and just want to appreciate everyone's testimony and comments and their time they've taken to be here with us in this conversation and dialogue, and just appreciate the service also of many who spoke. We are going to move to lunch, and we are going to return at 1:20 to reconvene. 1:20 to reconvene. Thank you. Well, welcome back. I will ask that the facilitator calls the roll as we reconvene.
Good afternoon, Dr. David Carlisle.
Present.
Dr. Sandra Hernandez.
Present.
Secretary Kim Johnson.
Present.
Richard Cronick.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Dr. Richard Pan.
Present.
Don Molds.
Present.
All present.
Wonderful, thank you. And actually, before we turn it to the next agenda item, I'm going to just take the privilege here of the chair to just ask the board, given both the presentation and public comment, if there's any additional direction you'd like to give to staff as they're thinking through the recommendation for this hospital sector target. So we can go in order. If anyone's ready to give some reflections, want to just give that space and time. Okay, Richard, please.
Maybe we'll start at this end. I think, and we've been discussing this for several meetings, and I appreciate the staff work on all of this. In many ways, I think what we're doing is that we're creating a filter, right? And of course, we want to be sure we're treating everyone fairly, and that we're doing it in a systematic way. We're not picking and choosing people because of any particular personal or other agendas. I know that's a concern that's been raised. I do think that we also hopefully understand that there are potential flaws, whether it's data flaws in data collection or whatever, that circumstances that may. So I think one of the things I think is going to be particularly important is not only, of course, this front end work that we're doing, but also perhaps also developing some sense of what the back end work will do. Okay, fine, you're on the list, right? What does that mean, right? If you're a hospital that's trending in the right direction, what do we do? Do we try to do everything up the front end, or what do we try to do? But then providing some guidance there, right? We heard from Barton. Well, I guess we have to look into it. But also, it's kind of like saying, these are some principles for if we catch you at the front end, but then we have that conversation. Here's some guidance as to this is what we're going to be doing at the back end, to be sure, right? We talked about systems. We talked if you're just rural, et cetera. So maybe probably trying to figure out where we incorporate that discussion so that people know that if you're caught in the initial list, before we actually hit you with whatever cost target we hit you with, and then of course if you exceed it, that what are we going to do at, I guess, the other end when we look into who's on the list and digging in a little bit more, what sort of principles will we be applying to say, well, maybe at this point, after we now had that conversation, whether it was a data flaw or whatever else, or unique circumstance, you might actually come off that list as well before we actually impose the rules. So I think that might be helpful as part of the process.
And I would just say that I want to commend the staff for doing a really good job at navigating some very, very complex and difficult waters, especially for the transparency and even-handedness of the process. I mean, I enjoy hearing the public comments that everyone brings to the conversation, and I think this is an example of what I'd call good government, and how the office and the department and everyone else are working together to kind of achieve a functional middle ground. That is going to move California forward, and I think that we're making definite progress in that regard. Thank you.
I think, likewise, you all know I'd like to go faster, do more, but I think you really have struck a good balance here. In particular, taking very highly complex technical issues and distilling them to a fairly easy to explain and quite rational formula for moving forward with the high cost outliers. I look forward to reading all the public comment after the 45-day window, but no, I think you've set us up quite well for this.
Thank you. I'm also supportive of the approach. Two things that might be helpful. I'd like to know more at some point about the communication, like how hospitals are notified, particularly if the list shifts, sort of what is the communication process. And then also I'd be curious about, and it might be qualitative data, I don't know, but learning more about the sort of impacts of the changes, because we heard a lot about concerns about access. I think we all share those. But I think there will also be a significant learning opportunity, particularly if the hospitals are successful in reducing their costs, learning sort of what the impacts are on the community. So that would be a nice to have. Thank you.
I add my support and commendation for the work. Seconding Dr. Pan's comments, I think dealing with data quality is important, and probably giving each hospital on the list the opportunity to say, well, even though this is audited data and we submitted it, we did something wrong, and then trying to figure out how to respond to that if those statements are made. And broken record, every meeting I talk about systems, and we've heard a lot about systems here, and I think trying to have some plan moving forward for what kind of data collection is going to be done, and prior to that, kind of the definition of systems, and I would start with suggest starting with the definition that ARC used, the HRQ used in their compendium project, and potentially moving from there. But we've heard and will continue to hear lots of comment on that, and I think it is a legitimate point that we need to be working towards resolving. But thank you.
Yeah, I would add my appreciation for the staff. This work is complex. We're a very diverse state. The circumstances in any one place are always unique by definition. The data is imperfect. We've heard a lot of concerns about access, but we also have real access problems now that this board has heard from, really from the very beginning of our existence. The lack of affordability, the concern about using coverage because they can't afford it. And so I think we need to get started, and I think this is a very good start. I think we will learn a lot as we go. Hopefully the data will get better. Yeah, I think continuing this conversation both with our advisory board, but also with the hospitals themselves to really understand what they actually can do to drive down costs and make healthcare more affordable in their jurisdictions as well as for the state. So I'm very supportive of where we are at this point.
I think anything that I would have had to contribute has been contributed, so I'll just say thank you as well, and appreciate the comments and the discussion.
Thank you all for that. And I'll just add again appreciation for the work. The only other thing I would add, maybe add on to Dr. Pan's comment, is that if there is something additional that we are learning through a particular approach that any particular hospital is providing, or a correction on data quality, just looking again at our ability to apply that to all, like what is that, a rerun, if you will, of the information, and then also utilizing those particular information points for us on our improvement on data collection quality in the long term. So those are just my two additions, but again, want to appreciate again the conversation today and the work to prepare us to getting to this point. Thank you. With that, we will move on to item 4B, proposed hospital sector definition regulations. And Vishal and CJ, I'll turn it over to you.
Sorry, all right. So I'm just going to provide a quick update. This shouldn't take but a few minutes on the hospital sector rulemaking. Last month, the board voted to establish hospitals as a sector. So we have the draft regulations, which we'll share in just a minute. We have a public workshop on March 3rd. We will share the draft definition with the advisory committee on March 25th. We will then return summarizing what we've heard to the board. We'll have a follow-up discussion in March. We'll also have a board update in April. We'll submit to the Office of Administrative Law in April, and then the regs would become effective in the spring of 2025. The draft text on the next slide is as follows. So healthcare sectors pursuant to, so We would be establishing the healthcare sectors pursuant to Health and Safety Code Section 127502. As follows, the hospital sector includes the following. It's general acute care hospitals as used in Health and Safety Code Section 1250 Subdivision A, acute psychiatric hospitals as used in Health and Safety Code Section 1250 Sub B, special hospital as used in Health and Safety Code Section 1250 Sub F, chemical dependency and recovery hospital as used in Health and Safety Code Section 1250.3 Sub A1, and psychiatric health facilities as used in Health and Safety Code Section 1250.2 A1. The reason that the regulatory language is drafted as such is the motion was to establish a hospital sector that was inclusive of all hospitals. These are the hospitals in Health and Safety Code Section 1250. So this is just to add clarity in terms of exactly which components of Health and Safety Code Section 1250 are included in the hospital sector definition.
Questions or comments from the board? Then I will open it up for public comment on the regulations.
We'll now take public comment on this item. Please step to the podium or virtually raise your hand. Noting for the record, we have about 98 virtual attendees and one hand raised. We'll start with Travis West and then we'll go to the podium.
Hi there, good afternoon. Thanks again for the opportunity to comment. Travis West, Regulatory Policy Specialist with California Nurses Association. Thank you also to OCA staff for their work in putting together this draft regulation. We're encouraged that OCA is proposing a definition of hospital sector that does not include blanket exemptions or exceptions or adjustments upwards of spending targets for certain sectors of hospitals. No exemptions or modifications of the spending target upward are warranted for any hospital sector, nor is there a formula or a top-line metric that would accurately and fairly determine which facilities would fall under such an exemption without undermining efforts to lower costs and creating opportunities to game the system. Thank you.
Thank you. To the podium.
Beth Capel on behalf of Health Access. We also support the proposed regulation and would oppose any exemptions or exclusions. We're particularly pleased that, gosh, within a day of our submitting our letter asking that Kaiser not be excluded, here it is, it's included. So we're pleased to see that. And we're also pleased that as Dr. Pan's legislation requiring Kaiser to report by individual health facility takes effect, it's now only been in effect for a few years. We will eventually get 5 years of data allowing us to compare Kaiser to other hospitals. So sometimes it takes a little time for all things good to come, but here we are. Thank you.
Thank you. Seeing no hands raised virtually and no one at the podium, that concludes public comment on this item.
Thank you very much. So we will look for additional comment through the regulatory process on that definition and appreciate the work. The next item is item 4C, the baseline report content preview. And I will turn it over to, is it Andrew Fair, who's going to present on this item?
So I'll be providing, along with Andrew, a review of proposed content for the baseline report. So this past fall, as we've discussed at the board level, OCA has collected TME or total medical expense and enrollment data from submitters. So using those data, among other data sets, the baseline report will include the following healthcare spending analyses based on calendar years 22 and 23 data. So we'll be able to report statewide total healthcare expenditures. We'll be able to report total healthcare expenditures by the three main market categories of commercial, Medicare, and Medi-Cal. And then we'll also report TME by service category, region, and payer. And then within payer, we could break out by market category as well. So the deadline for this is the report needs to be published on or before June 1st of 2025. We currently have commercial and Medicare data in-house, and we're in the process of analyzing this data. With respect to Medi-Cal managed care organization data, which we're leveraging existing data from DHCS, we've obtained 2022 data, and we'll soon be collecting 2023 MCO data from DHCS. And then on the next slide, I just want to discuss what will not be included in the baseline report. So we won't be including physician organization level reporting. We did ask submitters to attribute spending to physician organizations using some instructions we included in our data submission guide. So we asked them to attribute spending to capitated delegated arrangements. The second step was to attribute any remaining spending to ACO arrangements. And then the third was a payer developed approach, which typically is some type of primary care attribution. This first round of data collection was a learning year for OCA, as well as the submitters, and we'll continue to refine our approach. We do intend to report on physician organizations as soon as we can, but we do want to provide some caveats of why it's not in the baseline report. So currently there's no single source of truth for physician organizations in California. We have partial lists based on a list of capitated providers from DMHC, the list of risk-bearing organizations from DMHC. So we have part of the universe, but we're still working on getting to a more concrete list. As we collect the data for year 2, which is going to be due in September of 2025, we'll focus on instructing the payers to attribute spending to the largest physician organizations. We're currently in a process of collecting organizational tax ID numbers, which will allow payers to validate that they're attributing the spending correctly to the right physician organizations. So we'll be providing those TINs to the payers, and then the payers will be performing the attribution. And then moving on to the second bullet listed here, we're not going to be measuring against a spending target because this is historical data for 22 and 23. And then APMs and primary care analyses won't be included in this report. The first round of data collection for these two categories is due September 1st of 2025. So they'll be in the following report on 23 and 24 performance. We'll include APMs and primary care. And then on the next slide, before I turn it over to Andrew, just want to note that the purpose, one more slide. So the purpose of this presentation today is to preview some of the analyses and show how the data is going to be presented and get the board's feedback as well as the public's feedback. The exhibits on the upcoming slides don't contain actual data, but are intended to be illustrative. And I'll hand it over to Andrew.
Great, thanks, Michelle. All right, so starting at the highest level here on this slide, it's an example of how OCA intends to present statewide total healthcare expenditures. So this is pooling that total medical expense concept with administrative costs and profits. And so we would show, for example, on the left, the aggregate statewide THC, and then on the right, those per capita THC numbers accounting for the population of California in those 2 years, and then their corresponding year-over-year changes on those two metrics. And just as a reminder, so I think folks are generally aware, but TME includes claims, non-claims payments, as well as member cost sharing, so co-pays, deductibles, and co-insurance. And on we move to the next slide. So this next slide shows aggregate THC disaggregated by TME and administrative costs and profits. And so this lends itself to being able to see the absolute dollar amounts of TME as well as administrative costs and profits, and then the respective percentages as a share of total healthcare expenditures. And then we would also include the year-over-year percent change in each of those respective components of THC. I would just note we don't have comprehensive administrative cost and profit data for all programs. We do have them for the major market categories, but for some of the smaller programs, we wouldn't be able to capture every dollar on that particular front. We can go to the next slide. So here's a similar breakout where we'd be disaggregating THC not only by its constituent units, but also stratified by those major market categories of commercial, Medicare Advantage, and Medi-Cal managed care organizations. And those would be the three main market categories where we have comprehensive TME as well as administrative costs and profits. Next slide here. So this is going to be aggregate statewide THC by a more granular set of market categories. So you can see there we have duals and DSNPs as well as a category for other programs in the state where healthcare spending occurs. So those would include data we've obtained from the California Correctional Healthcare Services, the Indian Health Services, the Department of Veterans Affairs, as well as some other programs that DHCS or the Department of Healthcare Services administers as part of its program. And then you'd also see the corresponding year-over-year percent changes from 2022 to 2023. Next, we would show overall enrollment by market as well as their respective year-over-year changes. So this gives this will provide some insight into the comprehensive share of the California insured landscape that OCA is capturing, breaking out commercial, Medicare, Medi-Cal, other, and then duals and DSNPs in their respective shares of the total insured market in California. And if folks have questions, feel free to ask away, or we can just mosey on through these slides.
Since you made the offer.
Sure. Yeah.
Thank you. I don't mind waiting. I was just curious, how does this reflect health plans? Like when you say administrative cost and profit, is that just the provider? Is that the health plan?
Those would be health plan administrative costs and profits obtained from DMHC as well as CSIO MLR reports that we're using for extracting that information.
Okay. Thank you.
Richard, and then we'll go.
Thank you. And I know you're just sort of midway through. And I realize this is really hard to capture, so it may just have to be an asterisk. But I think, as we're looking at trying to reduce healthcare costs and spending, we also have to acknowledge there's a lot of administrative costs on the provider end, and it tends to be all counted as healthcare. So, when we do the sort of the so-called medical loss ratio, the medical loss is only on the plan side. So when a practice has to hire another person to deal with prior authorization or billing or spends more on billing services and so forth, that's an administrative expense. That's less time with patients. So I realize that might be hard to capture, especially now. I don't know if there's some mechanisms we might explore in trying to do that, whether a medical group or something might try to capture some of that, or maybe some researcher might do a sample and try to figure this out. So it may just be more of an asterisk, but I think it's important to recognize that whatever administrative costs we're capturing is only on the plan side. And again, if there's a way to reduce on the provider side too, obviously we want to capture it back for the patients, right? And for the consumer, not, to just turn, but at some point we got to look at that. The other actually interesting question is that one of the things we talked about at the very beginning is public health and how we underfund public health. And so, of course, they don't necessarily go through plans or something. They provide things like STI treatments and other types of things. And whether there's some way to, and most of course, is government, right? It's either the state or the counties or some cities, et cetera. I don't know if there's a way to capture. Those are in budgets and so forth. But whether there's CPH could help with this, or some other, or CSAC or someone, or HEAC, right? Basically, HEAC. Basically, is there a way to come up with an estimate of the spend on public health, especially if it's related to whether it's just clinical or all of public health? So that we at least can put that as a relative part of this total THC, right? So when we think about where we want to invest money in, right, so that we don't lose that. Otherwise, it's out of sight, out of mind. So just a couple of things based on what you've presented so far, and I appreciate it. Thank you.
Michelle, in your baseline report, you mentioned the things that would not, at least initially, be included. What's the timing and thinking on the behavioral health spend?
So today you'll be receiving an update from Margareta about that. So it's staggered. We focus on APMs and primary care, and then the board has a upcoming decision in front of them to approve the behavioral health investment benchmark. And then once that's approved, we approve the way we define behavioral health service, or OCA would define that, but the board would approve the benchmark. And then we would need to promulgate regulations for data collection. So it wouldn't be until September of 2026 where we would collect that data. Yeah, but we are hoping to have some baseline estimates from the sibling departments. We're looking into that, whether through the respective state coverage programs, what are they seeing as a baseline level of what's currently being spent on behavioral health?
Yeah, I mean, we're going to have the conversation this afternoon. We'll develop a benchmark. We are spending a lot of money in behavioral health today, and mostly public programs. Not exclusively. There's also the cottage industry of what people pay out of pocket, but behavioral health is such an important part of what we're trying to achieve in the state. And so whatever that timeline is and however we can accelerate that, I would be a proponent of.
I was just going to ask, sort of following up on what Richard was discussing. Can you sort of lay out? I understand that you're reporting out or plan to report out plan administrative costs, but can you sort of talk through what I'm assuming we should care about that? We should care about hospital administrative costs. We should care about medical group administrative costs. Can you talk about what's out there, what you can reach, whether you can reach anything else? I think there may be a window into hospitals, less of a window, as I understand it, into medical groups. And then, he raised an interesting question about whether there might be some, I look at you, alternative way of getting at some of these pockets where we should care.
Yeah.
Sort of, yeah. Maybe start with
Yeah, and so I think certainly for the baseline report, the intent is to, just given that we've identified a readily available data source to focus on payer administrative costs and profits, I think there's a comparable equivalent on the hospital annual financial disclosure side. We will not be reporting on specific hospitals in the baseline report. We would be, and you'll see in a couple slides, payer level total medical expense growth. On the physician organization side, as Michelle noted, it is quite a thorny landscape. So we're open to suggestions if folks have ideas on how we would be able to get to some approximation of THC at the physician organization level. But for now, we do have 2022 and 2023 TME as attributed by physician organizations along the lines of what Michelle described, but we don't have that sort of readily available data source for the administrative costs and profits.
20 years ago or so, Jim Kahn, I was co-author with Jim Kahn on an article that tried to estimate administrative costs for medical groups and hospitals. And on the medical group side, we use some data from MGMA and a couple other data sources that, was not perfect. It would take some effort, but, with some resources, OCA could get estimates of administrative costs on the medical group side, and I do think it would be, worthwhile moving forward to try to keep track of that.
I'd add, we do have the authority to collect audited financial statements. It's in the statute for physician organizations. Right now, we're focused on identifying them before we start collecting data, but it is on the roadmap in the future. So that we could derive admin costs and profits likely from the audited financial statements.
I mean, profits for medical groups is I'm not sure that that's a kind of meaningful thing, right? It's income really, and whether we want to get to that or not, I'm not so sure. But at least the administrative cost part, certainly.
Yeah, I would just agree. It was what I was trying to get at initially. Like, I think it is really important to understand administrative costs on the provider side, particularly if we're going to start looking at systems, where I think you're going to see even more. And I think we may see a correlation between sort of administrative burden from the health plan side versus, and then the administrative costs on the provider side. And I know there's some research that shows that it's like $20,000 per physician in the US. So I really do think if any way we can get at both sides, the administrative cost is important.
On the hospital side, from the annual financial disclosure reports, you can create some estimates of administrative costs, and so, that's data that you have now and could report on.
Ian and David.
Yeah, I want to echo Sandra's point on behavioral health, and I don't want to slow down or replicate or create a parallel calculation for behavioral health, but I believe, I'm fairly certain, all of the plans have a fairly good idea of what they spend on behavioral health. They report it to us in our rate renewals. I think it ranges somewhere between 1.5% and 2.5% of total spend of the plans. That ought to be a number that they could feed into us quite easily, I would think.
And actually, Ian just captured my comment as well, so thank you very much.
We do need to have the agreed upon definition of behavioral health. So I don't know what you all are using when they report that to you, Ian.
That's whatever definition each plan has an understanding. It's not what we will be using for our behavioral health benchmark, but it is a data point along the way.
Okay, Andrew, we'll turn it back. There's the first set of questions for
Sure.
you.
Great. Glad I paused. Thanks for all the feedback. I think we made it a little bit further. Maybe one more. Awesome. Okay. And so, as has been made apparent through various comments, it's a little bit easier for us to be able to extract from various data assets total medical expense by market category, as well as the corresponding member months, which we can then use to compute these PMPYs, or per member per years. And so in the baseline report, we would include total medical expense per member per year for the various market categories you see on this slide, along with their year-over-year relative change. And then the next slide, we would also report payer by market category level TME growth rates. So we have this data available both through the data submission guide as well as data exchange with our partners at the Department of Healthcare Services. And so in the baseline report, we would include TME per member per year growth rates for a commercial, Medicare Advantage, and the Medi-Cal managed care organization market categories. And then here's just an example of those commercial payers. We'd also provide information showing payer level enrollment shares for the commercial, Medicare Advantage, and Medi-Cal MCO market category. So here on this slide, we've got the commercial and the MA payers and their respective enrollment proportions. And then the next slide will include the Medi-Cal managed care organization enrollment totals. So summing across those three categories, right around 33 million equivalent member lives, and then we also stitched together other corresponding enrollment from some of the smaller programs in the state, from the VA and some of the other healthcare spending that happens across the state. And then rounding out the set of analyses on the next slide would be total medical expense by region. So in that first year of the data submission guide, this was primarily oriented around the covered California rating regions, with the exception of Los Angeles County, which was at the service planning area level. And so we'd be able to show total medical expense in absolute dollar amounts as well as their relative growth rates from 2022 to 2023. The one note about the nature of OCA's regional total medical expense data is it doesn't include non-claims payments aside from capitation, since line items like shared savings payments and incentive payments are usually lump sum payments to providers and not readily attributable to specific patients and thus to regions. And so it's basically a rounding error in terms of total TME, but just want to be transparent about what won't be included in the regional TME data in the baseline report. And then the last type of analyses you'll see in the baseline report would center on total medical expense by service category. So the categories that were outlined in the data submission guide include hospital inpatient, hospital outpatient, professional, long-term care, regional pharmacy, and other services category, which include things like optical services, transportation, hospice, among other categories of spending. And so you'd be able to see aggregate amounts of claim spending by service category and potentially PMPYs as well, just to help understand how much each of these respective categories contributes to spending. And that is that baseline report preview. Happy to answer any additional questions folks may have.
We'll go to, oh.
Yeah, I just wanted to briefly note, we've, at the board level, we have talked to, we've had UC Berkeley Labor Center come and talk about recommendations for including consumer affordability measures, such as changes in premiums and out-of-pocket costs and other metrics. So we'll have some of those as stage setting before we launch into the analysis of the submitted data. But and then future, we'll build on that going forward and kind of have more in-depth data points on consumer affordability. There's some potential to get some data from DMHC as well, but just wanted to flag that.
Okay, I saw Richard, then Rick, then Ian, then David.
So just a question on this slide on by service category. As I'm looking at long-term care, I just want to know which data elements we're capturing. I assume we're capturing Medi-Cal as well as, because, for example, in terms of long-term care, who's paying for it, right? Well, it's going to be Medicaid for most of it. Long-term care insurance, I'm not sure what portion of that, but that's not what we normally collect data from. So I don't know, are we going to get data from that or not? And I don't know what portion of it then is also covered by, commercial or other insurance. But for example, Medicare doesn't provide much long-term care, but most commercial health plans don't provide, I don't think, provide much long-term care coverage. So when I'm seeing long-term care, I think it's really important that we capture that, especially with an aging population. But I just wonder how complete of the data we're actually capturing that's long-term care. So when that bar that says long-term care, how much of long-term care are we actually capturing?
Yeah, it's a great flag. So through the data submission guide, which is primarily commercial, Medicare Advantage, and then D-SNPs and duals, we would capture those those service categories. As part of year one, we did grant an exemption to the MCO plans and tried to squeeze as much blood from turnips as we could to make use of existing reporting that the MCOs do to DHCS. So it does enable us to understand the enrollment within the MCO market as well as the aggregate TME and payer level TME, but we don't have necessarily the same granularity of service category spending that you would see in the data submission guide, nor would we have the same regional granularity that you see in the data submission guide. So there are some gaps between as we try to stitch together some of these different data sources.
Okay. So I would guess is that this is, again, one of those places where asterisks start becoming important, that, given the data sources that is composing this, and I think, again, I really appreciate you include long-term care because I think it's important people to know, but there might have to be an asterisk, like there's other major sources of funding for long-term care that's not incorporated in this, therefore make the magnitude of this look smaller than it is in reality. We should make note of that, at least, so that people don't look at that and go, oh, look, long-term care is this portion. Because, again, with an aging population, when I was chair of budget, the subcommittee on health and human services, we were looking at the trend line for long-term care, LTSS services, and the population change. And it's going to be a significant budgetary issue. It is a significant budgetary issue. And so as we're looking at total healthcare spend and incorporating long-term care, I just want to be sure we acknowledge, even if we don't have the data, other sources of funding for significant sources of long-term care funding that we may not be collecting as OCA when we present the data. Thank you.
Thank you. Thank you for the presentation. I'm, as a data nerd, excited to see this report. And thank you, Vishal, for bringing up consumer affordability, which does seem like a notable, I mean, we've talked about how important that is. And just to make sure I understood, so you are planning on an additional set of tables to what was presented today that will give us information about out-of-pocket spend in 22 and 23 and changes in out-of-pocket spend from 22 to 23?
Yes, through the TME data that we can collect out-of-pocket, or we do have a data element for member out-of-pocket.
Yeah.
And we're looking into whether we could report that by region as well, because there might be some trends there. And then other facts and figures from the literature pertaining to consumer affordability. That will be more in kind of a narrative format.
Yeah, I mean, I think at least on the narrative format, bringing in, information from the, Kaiser Employer Survey and the AHRQ MEPS data on what we know about premium payments we won't have California specific from MEPS, but at least you've got the Western region, and Kaiser, I think, probably does have California specific, kind of how much are California's paying for premiums, which I know you won't have in the total medical expenditure data that you're collecting, but it'd be useful to include that because it's a very important part of affordability. And then I would sort of adding on to Richard's points about asterisks, I would suggest, and I realize this is additional work and June is pretty close, but more than asterisks, a section that compares sort of what we're capturing here to other things we know about health spending in California. So we're going to have, total health spending from what we're capturing. How does that compare to what CMS thinks about for total health spending in California? Not that CMS is necessarily the gold standard, but it's kind of at least out there. And, that would illustrate, I think, Richard's point that long-term care, well, we've only got a very small part of long-term care spending. We hopefully have a much larger part of hospital and physician spending, but I doubt it's going to be 100%. We could also compare what we're capturing for hospital spending here with data that HCI has from the annual financial disclosure reports on hospital spending. But more generally, how complete are these data? And I think that would be helpful for the public as well as us as a board to understand, what part of the universe we're getting here. And then the third comment, so the first was about affordability, the second is having some section that tries to, put these data in context. And the third, I wonder, but given the conversation we had this morning, whether some information from the annual financial disclosure reports about hospital spending and changes in hospital spending from 22 to 23, both in the aggregate and potentially for specific hospitals, would be useful as we think about applying the hospital sector targets moving forward.
I'm just going to come in with a little bit of protection of my team who wasn't planning on doing all of the data to get to the hospital sector targets. So I'm a self-avowed data geek without your credentials. And so I just want to, I think we'll do as much as we can. And I also just want to say they've had a lot on their plates, but very helpful points that we'll look at.
Yeah, I take your point loud and clear because, and I want to say 4 years ago, CHBUP and the UC Labor Center disagreed about total healthcare spending by something to the tune of $200 billion. So this set of reports is such a huge leap forward, and I really think you're doing extraordinary work here. Thank you, Vishal, for saying what you did about affordability. That is the most glaring piece for the Office of Healthcare Affordability. To not have that in the initial baseline reports would be problematic. But I do, with regard to Rick's statement about, I don't think affordability need just be the out-of-pocket. And I do think maybe we do have the data already. I would argue that all the spend that is paid for through commercial plans, whether it comes from employers or it comes from individual paid premiums, that impinges directly on affordability. I don't think it's that difficult to say in the state we are spending 20% or whatever the number is of median household income, and that went up at X percent compared to household median income, which went up Y percent. I think we have the data in these charts that you're describing to do that math. So that would be one point, and the other, just on the service categories and the regional charts. I wonder if you couldn't do that by region, since you have the data by region. I think that would be important for equity analysis here. And maybe one day, not in the baseline, but at some point aim to get to a point where we can further break down the commercial by individual small group, large group markets. I know we have that for enrollment, but maybe not for TMA just yet, but maybe that's somewhere we can get someday.
Yeah, we're currently just breaking it out by commercial and HMO, PPO. We could think about other market segments in the future.
And this has been covered, I think, largely, but I just wanted to underscore Vishal's comment, but the others have been made as well, about having or keeping in mind the consumer perspective on this. And we're doing, I think, a pretty wonky, intensive kind of analysis, and we're trying to change an environment, of course. But if the consumer can have something that they can understand about healthcare cost, the Federal Reserve uses their market basket. I don't know if there's such a thing like that in healthcare, but a standard package and how much it costs and how much it varies, that type of thing, I think would really connect this effort to your average Californian in a way that would be very relevant. Not to add more to the plate.
Just to maybe layer on a little bit with what David said, I don't know what degree, obviously we have standardized plans for covered California. I realize not all the commercial market is, but, there may be some similarities. Just thinking about what a model basket might be that you could, but trying to translate, right, exactly, translate all this data into something that, that someone who isn't as wonky as all of us, self-declared data geeks or nerds, can sort of grasp hold of, so they can understand both are, where we're trying to get to, right? It might be helpful. So I realize you have enough dealing with all of us data geeks and supplying us, but someplace as we move along after the baseline, we may want to think about how we translate this into something that's a little more digestible for for our brave Californians.
I have no idea what to do with this, but I'll throw it out because and David's comments triggered it. So as I've been thinking about this, I'm looking at it from a large purchaser's perspective, and one of the things that we see when we do deep dives into spending of particular, say, hospitals or systems that we're negotiating with or that our plans are negotiating with, and we have an interest in understanding better, is that when you actually go through, particularly with hospitals, we find when you actually go through the prices, you see it's so we see pretty consistent inconsistency in that we'll see huge spikes in what they may be paying for, say, injectable or hospital administrated drugs. Thank you, and really low prices for certain procedures. So at the end of the day, it looks like you're just sort of trying to make the math work in a lot of cases. We see that a lot. that for us is fine in a oddly because we care about the sort of rolled up costs. But when you think about these consumers, and I was thinking about it when we were hearing our friends from Monterey, for a consumer, that those kinds of differences could be really significant and really horrible. And I don't know what we do with that, but as we're thinking about how this rolls out to consumers, a lot of the folks that are here are in, particularly in Monterey, as I've learned, high deductible health plans where they have high cost exposure to particular types of procedures, and so for some of them, those differences could be pretty catastrophic. And I just, again, I don't know what we do with it, but it is certainly important from a consumer's perspective, and we should at least be thinking about that.
You asked, and we had some thoughts on it. Appreciate the work and the offer and opportunity to figure out what else we could do to better demonstrate and progress and have a good content to display. With that, we will open it up to public comment.
We'll now take public comment on this item. Please step to the podium. Those online, please raise your hand. Seeing no hands raised online, go into the podium.
Beth Capel with Health Access California. I want to thank the staff and the board for raising the issue of affordability. It was a notable gap when we opened up the slides and saw nothing on affordability. So since we have been from the beginning, you're all right. It's called the Office of Healthcare Affordability for a reason, and that focus on the consumer has been very important. I would point you, the Department of Managed Healthcare, as a result of a series of bills that a number of us have been engaged in, does annual reports on large group, small employer, and individual coverage. And the work that the Labor Center has done was an attempt to begin the conversation about pulling together some version of a market basket that would look at the variety of healthcare costs. What I took away from that work is there's no one measure. It's not actuarial value. It's not premium. We're in a world where 20 years ago, 30% of Californians with employer-based coverage had a deductible. Today, it's 80. We're in a world where apparently everybody in Monterey has coinsurance and high deductible coverage. That means when they need one of those injectable drugs or one of those drugs where the hospital marks it up by 800 or 900% above Medicare, they're paying for it. And that's what we're all trying to get our arms around. And so I think it's going to take some iterations to get to the equivalent of a market basket. And it's going to take being mindful of how costs are changing in the market. 20 years ago, we wouldn't have thought of deductibles in the same way in California, and now it's huge. So that's, I think, really important for the work going forward, and it will probably take more than one iteration to get it right. On another point, I want to apologize for laughing out loud about a study Jim Kahn did on administrative cost. But he has recently updated it for the California Health and Human Services Agency work around SB 770. And I think it will be, there's a forthcoming report that UCLA is working on that I think we will see some of that. It's an important topic, and there is a whole lot of administrative costs hiding at the provider level. And Jim Kahn has been raising that issue for all of the decades I've worked with him, dating back to the early 1990s. So thank you.
Thank you. Looking virtually, noting for the record, we have about 91 attendees and one hand raised. Anna, you want to go ahead?
Yes, thank you. Can you hear me okay?
Yes.
Great. Good afternoon. My name is Anna Aguillon, and I am the CBO of the Salinas Union High School District. We are the largest public employer in the Monterey County and the largest school district in Monterey County. As a CPO, I am aware of the disproportionately high cost hospitals in Monterey County and how the rate structure has driven up the cost for commercial insurance payers. Our district is in support of the 1.8 target for the Monterey County hospitals in order to control the out of control rates we are constantly chasing to provide health care to our employees. Thank you for your work in helping all of us have access to more affordable health care. In Monterey County, we are already paying such high rates. Any support will help, but we are still in a very difficult position as employers. Thank you for your time and for allowing me this opportunity to speak.
Thank you. To the podium.
Good afternoon. I'm Laura Lucia, the director of the healthcare program at the UC Berkeley Labor Center. I wanted to appreciate the good board discussion just now about consumer affordability metrics and how important they are, and appreciate that OCA is going to use those kinds of metrics to set the stage in the baseline report. We're also glad to hear that you'll be including the member out-of-pocket portion of total medical expenses. And it's exciting that we're going to have that data in the state for the first time. There are gaps in the existing data, but we're fortunate that we do have a lot of good data sources in California, both on the administrative and the survey data side, including the MAPS-IC data on California deductibles and premiums, DMHC data on premiums and actuarial value, and the CHCF Health Policy Survey, which has great data on trends and delays in care and medical debt and other consequences. Since OCA is tasked with controlling the growth in per capita spending on healthcare and ensuring that consumers benefit from that reduction, it's great that you're going to be monitoring consumer affordability metrics in these reports. Thank you.
Thank you. Looking virtually, seeing no hands raised and no one at the podium, that concludes public comment on this item.
Thank you very much, and we look forward to continued conversation on that topic. We will move now to item 4D, proposed total healthcare expenditure regulations and the summary of public comments. Welcome Margaretta and CJ as well.
All right, contrary to what my staff may say, I'm usually not used to speaking this much in a day. So bear with me for the next few minutes here as we get through this. So we're just going to provide an update on the proposed total healthcare expenditures, data submission guide, regulations, and a summary of the public comments. This is a quick overview of the timeline for implementing what we lovingly call DSG 2.0. So in May, the submitter registration opens. In June, the submitters have the option to submit test files. Submissions opens for the 2023 and 2024 cycle in July. And during July and August, we'll have one-on-ones with data submitters. On September 1st is the deadline for the data submission, and in November, we'll have one-on-ones with the payers. And then in June, we will publish our annual report in 2026. So moving on to the next slide, I'm going to try to do my best to paraphrase and summarize these. We had a request to clarify scope of the proposed definition of affiliated. OCA intends to amend the term affiliation to affiliated for consistency and clarity. This would not have a change in scope or the impact on the term in any way. There was a concern that payments from the state for Medi-Cal providers, directed payments, are not yet settled by the September 1st submission deadline. OCA acknowledges that for some claims, runout may exceed the minimum 180-day claims runout period. OCA intends to use the initial data submissions from 2024 and 2025 to develop further insights into the impact that this 180-day minimum claims runout period on overall data completeness has. Next slide. And stop me at any time if you want to dive into any of these. There was a concern that the proposed requirement for payers and FIDs to complete separate data submissions for each licensed plan and or health insurer would have significant implications for the data. Because health plans and health insurers in California are separately licensed and regulated at the state level by DMHC and by CDI, respectively, most submitters are accustomed to reporting data for these license types separately and at the license level. Additionally, the Healthcare Payments Data Program already requires annual registration at the license level. So this is just to bring further alignment around that. There was a request to align how member responsibility amounts are reported across statewide TME, the attributed TME, and the regional TME files. And as such, OCA plans to restore the member responsibility data fields to the statewide TME file. Next slide. There was a recommendation to revisit the approach to how submitters report spending in the commercial and partial benefits market category. The methodology for estimating expenses in the commercial market category has not changed from the existing and approved data submission guide. The proposed data submission guide includes new fields in the submission questionnaire file to capture the type and amount of estimated expenses for more accurate analysis and reporting. There was a request to clarify how MCO data would be categorized in commercial, given carve-outs for many mental health and substance use disorder services and pharmacy. MCO data would not be reported or otherwise categorized in the commercial and partial benefits market category because the market category only applies to the commercial market. There's a recommendation to adjust the submission timeline to revise instructions so that submitters can estimate Medicare shared savings amounts for the prior benefit year. We will continue to ask submitters to use reasonable estimation efforts for non-claims. And again, this goes back to the prior comment, where we'll be evaluating the 180-day claims runout and 180-day reconciliation period in years to come. Go to the next slide. There's a request to clarify whether the proposed exclusion of spending on discounts and other member perks in section 4.3.1 of the data submission guide intends to exclude spending on mandatory supplemental benefits in Medicare Advantage plans. OCA plans to revise the DSG to clarify the exclusion. OCA does not intend to exclude the cost of mandatory supplemental benefits in Medicare Advantage plans, as these are part of plan required coverage beyond traditional Medicare. There was a request to clarify proposed exclusions of CMS reconciliation payments, such as Medicare sweep payments or Medicare Part D. OCA plans to revise the DSG to clarify this exclusion. Since revenue is not reported in the THCE files, the exclusions of CMS reconciliation payments ensures that TME reflects the actual cost of care provided without adjustments for post-reporting financial reconciliation. Go to the next slide. There was a request to clarify why OCA reduced the number of physician organizations listed in the attribution addendum. OCA developed the proposed version of the attribution addendum using actual data from the attributed TME files received from submitters during the September 24 data submission. OCA seeks to initially focus on larger entities, which, based on analysis of the reporting year 2023 data, would be physician organizations with greater than 5,000 attributed members across the commercial and Medicare Advantage market categories. Combining the identified organizations' attributed members with the unattributed population, approximately 20% of covered lives in reporting year 2023 accounts for nearly 90% of covered lives across the commercial and Medicare Advantage markets. That leaves in the current proposed addendum 145 physician organizations. Next slide.
Can I ask, this is actually sort of back to, it's really a question for Vishal, but since you raised it here, I didn't completely follow the discussion about not having anything in the baseline report on physician organizations. We don't yet have data that's good enough? Was that the sort of bottom line?
We do have data. It's just we instructed the payer. We didn't have tax ID numbers for all the physician organizations, so we relied on name matching. and it's not always a clean process. They kind of have to use kind of functions in Excel to kind of look up if something sounds similar, because names could be Acme Corporation, Acme Inc. But it's the same medical group. So we want to ensure that the payers attribute the spending appropriately by providing a tax ID number.
And what we have now is not close enough to be usable. I mean, this is obviously a really important area, and if it were possible in the baseline report to, even for the 50 largest physician organizations in the state or the 20 largest physician organizations in the state, begin to do some reporting on that, I think that it would be that would be useful.
We definitely have that interest as well. Like we've spent a lot of staff time on it, and we share that commitment and wanting to report on more provider organizations. But we just want to make sure that when we publicly report that we're confident in the data being reported.
And we're not confident even for, say, the 20 largest physician organizations at this point?
Not at the moment.
Okay.
Aside from Kaiser, which the Permanente Medical Group and the Southern California Permanente Medical Group, that could be potentially something we report on. But the other groups, we just want to, and then there's also relationships, in terms of how they roll up to a larger IPA or medical group. So there's some of that we want to make sure that we're doing appropriately.
All right, we can go to the next slide. There was a recommendation to explore pathways to ensure that provider entity spending is accurately attributed, reported, and consistently aggregated across payers. OCA acknowledges that because there is no existing comprehensive list of physician organizations operating in California with unique identifiers, many issues will need to be resolved with the continued involvement of stakeholders. And note that the attribution addendum will be periodically revised based on information that we receive from submitters as well as from provider organizations with the ultimate objective of more complete data. There was a recommendation to allow for public input from payers on a report draft to ensure data is categorized and described accurately. For example, shifts in spending from year over year may be due to membership changes, benefit mandates, and other factors. OCA conducted one-on-one sessions with each submitter in August of 2024 prior to data submission, and again in November to preview total medical expenditure calculations. At the preview session, each submitter was given the opportunity to provide feedback and or additional context for their data. OCA holds monthly board meetings with multiple opportunities for public comment, including from payers, and we'll continue to have those same one-on-one sessions this year as well after the next round of data collection. There's a recommendation that OCA and OCA's vendor OnPoint explore additional methods to streamline the error handling process during data submission. OCA and OnPoint are committed to continuously improving the data submitter experience. Webinars leading up to the submission deadline will include training on how to view automated validation errors on submission. Once files pass automated validation, there are additional manual validations that may require submitters to resolve discrepancies. OCA and OnPoint are also available for technical assistance prior to and during the submission process. There was a recommendation to finalize updates to the data submission guide earlier than March of the submission year. The question, can OCA provide more information on timing of future updates to the data submission guide? Any updates to the DSG will be discussed at multiple board meetings and proceed through the public comment process before submission to the Office of Administrative Law. Updates may occur annually as OCA fully implements its program. For example, OCA plans to update the data submission guide in 2026 to collect data necessary to report on progress towards future behavioral health investment benchmarks. That's all from me. I'll hand it over to Margaret.
Good afternoon, members of the board. Thanks, CJ. So this next slide summarizes 2 additional general feedback items. First, a commenter recommended that OCA work with stakeholders to develop an appropriate risk adjustment methodology prior to any enforcement actions. And as we've discussed before, OCA will not modify its risk adjustment methodology to consider clinical risk through these proposed regulations, and OCA currently collects data at the granularity needed to perform age-sex risk adjustment, and we will continue to assess the issue of whether clinical risk adjustment should be introduced into future reporting and remain open to other approaches. Second, a commenter recommended that OCA work with its sibling department, DHCS, to eliminate overlapping data collection efforts. And here we know that OCA is working closely with DHCS to reduce reporting burden across our programs where feasible. As such, starting this fall, Medi-Cal Managed Care Plans, or MCOs, will report primary care spending and alternative payment model data to OCA using OCA's methodology, and DHCS will sunset its related reporting requirements, and data submitted to OCA will be shared between the 2 departments. And we worked closely with DHCS to develop this process. Additionally, to minimize reporting burden for MCOs, the proposed regulations only required MCOs to report spending for the Medi-Cal managed care and dual eligible Medi-Cal expenses only market categories in the new APM and primary care files in 2025. And for all other file types, the total medical expense files, OCA will receive data directly from DHCS and CMS. And there is an option for MCOs to voluntarily report if they choose to do so. And on the next slide, turning to our new files, our alternative payment model, or APM file, and our primary care file, these next few slides summarize the feedback we received related to adding those files to this data submission guide. So the first comment recommended a language clarification change to use the term total amount allowed, which OCA plans to make. And the next comment requested OCA clarify how submitters should handle capitation payments that are developed based on risk-adjusted revenue. And here OCA notes that reported payments should match what the data submitter paid to a provider organization without any subsequent risk adjustment. Capitation payments that were developed based on risk-adjusted revenue should be reported as they were developed and paid to the provider organization. And the next comment requests OCA clarify why submitters are required to crosswalk their primary care providers to the annual network review file submitted to the DMHC. And OCA proposes this requirement in response to stakeholder concerns that using only primary care provider taxonomy codes to identify primary care providers would include some providers with a primary care taxonomy who may hold multiple certifications or subspecialties and do not practice primary care, therefore potentially overinflating primary care spend measurement. So this option to use the DMHC annual network review file that indicates primary care providers for physicians, nurse practitioners, and physician assistants who practice as PCPs was developed in OCA's investment and payment work group. And on the next slide, a few more comments related to the APM and primary care files. So this next comment requested that OCA include retail pharmacy costs related to the administration of vaccines in reported primary care spending. And here, as discussed in OCA's investment and payment work group, stakeholders were concerned that care provided at retail pharmacies did not align with the work group's vision for whole person comprehensive coordinated primary care. And as a result, OCA's measurement methodology for primary care excludes retail pharmacies as a place of service. Similarly, a commenter requested OCA clarify why only the administration of vaccines is considered a primary care service and not the full cost of the vaccine. OCA does not include the cost of the actual vaccine as part of its primary care spend, since this spending is not determined or controlled by primary care practices, nor does the spending on the actual vaccine support primary care delivery or transformation. Additionally, the majority of states that measure primary care spending do not include the costs of vaccines in their spending measurement. And on the next slide, here, on this slide, the first comment recommends that OCA allow submitters to estimate care coordination fees or care coordination payments in scenarios where a practice received capitation, but the care coordination payment are not distinguished as primary versus specialty care. And here we clarify that the OCA primary care spending methodology only intends to count care coordination fees as part of primary care spending if they can specifically be tied to primary care programs. And if the care coordination fee is embedded within a broader capitation payment, the formula for allocating a portion of capitation payments to primary care spending would apply. The next comment requests the office clarify how submitters should account for the fact that encounter data is incomplete from submitters or from providers. So OCA appreciates that incomplete encounter data may impact the spending allocated to primary care, and through actively using encounter data, we seek to incentivize payers to work with their providers to acquire more complete encounter data to support the accurate allocation of these payments to primary care. Here, we also received a request to clarify the hierarchy of expanded framework payment categories as it relates to reporting in the alternative payment model file. And so to provide greater clarity, we plan to revise the data submission guide to provide more details and instructions on the hierarchy. And in the next slide. So this slide summarizes 3 additional clarification requests. So the first request was to clarify whether in the APM and primary care files, the payment category we label as X, fee for service, includes retail pharmacy, and in response, we note yes, that this field includes retail pharmacy. Second, a comment requested we clarify why population health and infrastructure payments, that category within the expanded framework, does not include payer personnel or internal expenses. So the population health and infrastructure payments categories is intended to capture only those non-claims payments that are made to providers or healthcare delivery organizations that support care delivery goals, and not personnel or internal expenses, which are included in OCA's calculation of THCE, or total healthcare expenditures, as part of admin costs and profits. The third comment on this slide, again, is related to care coordination fee payments, and the commenter requested OCA clarify how care coordination fee payments should be categorized. So we note that the primary care payment allocation methodology asks that non-claims payments within a payment model are reported based on the intended use of the payment and their distinct payment subcategory to support our understanding of the intent of that payment. So the primary care spending methodology does not require spending to be allocated in a category furthest along the continuum of clinical and financial risk, and that allocation is only for the alternative payment model file. And then on this last slide, this next slide, this is the last slide of comments related to the APM and primary care files. And in public comment and in communication with DHCS, we received several requests to update the primary care code set that we use for the primary care definition, the claims-based definition. So in response, OCA plans to remove and correct several codes to reflect the most recent codes in use. And we plan to add new codes for telehealth evaluation and management, COVID-19 vaccine administration, and pharmacist subspecialties to align with the existing code set. These additional codes align with the codes already in the code set and the principles developed in the investment and payment work group to guide the primary care spend definition. So that is the last of the summary of the comments we received on the Data Submission Guide 2.0 revision, and we're happy to answer questions or pause for additional discussion.
Thank you for walking through.
a lot of detail here for us data geeks. On the, I guess, let's see, slide number 76, APM primary care files, and they said to request to clarify whether payment category X equals fee for service in the APM primary care files includes retail pharmacy. And I was trying to understand exactly. So the answer was yes, it does. For what type? So what type of services? Because I think, as you pointed out on the vaccine side, what we're trying to capture in primary care is sort of this coordination of care, that type of thing. So I'm just trying to think what aspects of the retail pharmacy are reportable as, I guess, as under payment category X is. So okay, how does primary care services anyway?
It's a good clarification for us to add. So in both the APM and the primary care file, in addition to collecting primary care spend, we also collect other spend. So it is not just what counts towards primary care that is included here. So the other fee-for-service payments would include the total claims payments, which includes retail pharmacies. So we're also capturing the total.
Okay, but that's not counted.
It's not counted.
Counted as primary care.
No.
Oh, okay. That's okay. So that's what I'm trying to sort out, because I heard primary care, et cetera. I was like, is it being counted as primary care or not? Okay, it's probably got total, but not as primary care.
Yes,
okay.
Correct.
Thank you for the clarification.
Other questions and comments? No, not seeing any. Okay, thank you. Public comment, please.
We'll now take public comment on this item. If you'd like to make a comment, please step to the podium or raise your hand virtually. To the podium.
Beth Capel for Health Access. We're pleased in reviewing this that the staff has done the thorough job of aligning these requirements with the actions that the board and staff have previously taken on things like primary care and alternative payment models. We were surprised to note that the estimate is that with the attribution addendum, you're capturing 90% of the covered lives across commercial and Medicare Advantage. And we wondered if we had understood that correctly, because that would be good. And we have been concerned that we were not capturing most covered lives in the attribution of physicians. So we would look forward to further clarification on that. Thank you.
Thank you. Looking virtually and seeing no hands raised. Noting for the record, we have about 85 virtual attendees. Seeing no one at the podium, that concludes public comment on this item.
Okay, thank you again very much for the overview and responses there from the feedback. We are going to take a 7-minute break. So if everyone could rejoin at 2:55, we'll reconvene. All right, we're going to go ahead. Thank you for being so prompt on the break. We're going to go ahead and get started back here. And a topic that we've teed up a bit here, an excitement that we have related to this next conversation, item 4E, the update on behavioral health benchmark, including advisory committee feedback. So I will welcome again Margaretta and Debbie for this presentation.
Thank you. So good afternoon, everyone. In this portion of our agenda, Debbie Lindis and I will present an update on the behavioral health work stream, and in particular our proposed approach to a focused benchmark for behavioral health spending and the feedback we received to date on this proposed approach. And in the next slide, just as a reminder, OCA's statute requires 2 related but distinct activities related to behavioral health spending. First, OCA is required to measure the percentage of total healthcare expenditures that go towards behavioral health. And second, OCA is required to set a benchmark for behavioral health spending that sustains infrastructure and capacity and shifts resources from specialty care towards supporting and facilitating innovation and care improvement for behavioral health. So on the next slide, first I'll provide an update on our proposed approach to measuring total behavioral health spending. And in the next few slides, we provide an overview of this proposed approach, which we presented to you all in December as a refresher. So on the next slide, this graphic shows the components of behavioral health spending that could be included in states' measurements. So behavioral health spending comes from several resources, as you have already identified today, including patients' out-of-pocket spending, state budget appropriation, spending for social services that support individuals with mental health and substance use disorder conditions. And to fulfill our statutory mandate, OCA is focused on the services that are part of total healthcare expenditures as defined, namely clinical services that are paid for by public and private payers through claims and non-claims payments. And as a practical matter that we've discussed before, the collection of behavioral health spending will start with a focus on commercial and Medicare Advantage, and we plan to add Medi-Cal health plans to our data collection later, and we're actively working with DHCS to define behavioral health spending in the Medi-Cal market. So we recognize that this is a relatively narrow view of behavioral health spending, and in the future, OCA will explore the possibility of using supplemental data sources to capture some of the other spending on this slide. We want to acknowledge the, in particular, the significant direct spending by consumers for behavioral health services. While OCA's current data sources will not be able to quantify the spending, OCA is studying out-of-pocket, out-of-plan, or self-pay behavioral health spending as part of a separate work stream. And we are collaborating with that work streams team to ensure that the insights gained there are shared across efforts. And this next slide should look familiar to you all as well. So this diagram shows how the definition of behavioral health spend can be determined by a set of diagnoses, care settings, providers, and services and treatments. And we are actively working with the investment and payment work group on the technical specifications for this spending, and we will update you on that aspect of our work the next time we meet with you all. And this next slide, again, should look very familiar as we've adapted it from our work on primary care. So here, OCA uses this equation to guide our behavioral health spend measurement. The numerator here is behavioral health spending, and total medical expenses is the denominator. Both the numerator and denominator have a claims and non-claims component. As you see in the note here, the numerator will include patient out-of-pocket responsibility for behavioral health services obtained through the plan, essentially for services for which a claim or encounter was generated. And the denominator will include pharmacy spending and all patient out-of-pocket responsibility for services obtained through the plan. And on the next slide, similar to our approach for primary care spending, OCA proposes to measure behavioral health spending using 3 modules: spending via claims, spending via non-claims methods such as capitation, and then a 3rd module, behavioral health in primary care, that will include both claims and non-claims spending. And we define this module as part of our primary care work and are reviewing it for potential adjustments in the course of our behavioral health work. So OCA will be able to include spending from the module in either primary care or behavioral health spending measurements, and we will also be able to analyze it separately to help inform policy discussions. And with this background, I will turn the presentation over to my colleague Debbie Lindez, Healthcare Delivery System Group Manager, to give you an update on our work developing a framework for the behavioral health investment benchmark.
Thanks, Margareta, for that introduction, and good afternoon, everyone. Sorry, hopefully this is the right distance from the mic. So I'll start off our discussion of the behavioral health benchmark framework by highlighting that OCA is proposing to make a distinction between the approach to measuring total behavioral health spending and to setting an investment benchmark. We're proposing that measurement take a broad view of spending and that the benchmark be focused on measuring a portion of overall behavioral health spending that reflects policy goals. This approach is illustrated on this slide with the lighter blue circle showing how the proposed benchmark data will be a subset of the data used to measure total behavioral health spending. Next slide. So more specifically, OCA's straw model proposal is that the benchmark promotes behavioral health investment that helps individuals receive more timely, high quality, and culturally responsive care in more appropriate settings and with less out-of-pocket spending. This would be achieved through improved access to outpatient and community-based services that are in-network. To support achieving this purpose, the benchmark would include covered in-network outpatient and community-based behavioral health services. We are considering excluding pharmaceutical spend from the benchmark, although we will be discussing that point further. So this proposal, oops, we can still stay on the prior slide. This proposal was developed with input from the Investment and Payment Work Group, and OCA will continue to refine its proposal based on feedback from the board and the advisory committee, as well as through further discussions with the work group. Now for the next slide. So here's a more detailed illustration of that relationship between measuring total behavioral health spending and measuring spending against a focused benchmark. The benchmark, the light blue inner circle, might focus on community-based and outpatient care settings, such as mobile clinic services, outpatient facility and professional care, including primary care and telehealth services. The service categories for the benchmark are a subset of those used for overall measurement. In addition to the benchmark categories that you see highlighted in light blue, the broader total spending measurement definition would include emergency department and observation services, residential services, long-term care, and inpatient services, which are represented in the dark blue outer circle. Next slide. So our straw model proposes that the benchmark promote more timely, high quality, and culturally responsive care in more appropriate settings and with less out-of-pocket spending. And the proposed benchmark framework supports these goals because its focus on outpatient and community-based care emphasizes prevention and population health and incentivizes increased access to timely and high-quality upstream care, which should reduce the demand for higher intensity settings. This focus aligns with other state policies such as SB 855 and SB 221 that address access and parity, and it complements Proposition 1's investments in the expansion of infrastructure for facility-based services. And I will share some more details about alignment with those policies in just a moment. The focus benchmark would help address California's access and capacity gaps, which are exemplified by the somewhat disheartening statistics on the slide here. These statistics come from analysis by the California Healthcare Foundation and Mental Health America of results from the Substance Abuse and Mental Health Service Administration's National Survey on Drug Use and Health regarding the current state of availability of services for adults and adolescents and on the timeliness of care. Next slide. Payers' behavioral health networks are lacking to the extent that more than half of Californians find it difficult to find in-network providers, and they use out-of-network providers 15 times more frequently for psychiatrists and psychologists than for medical and surgical specialists. A benchmark focused on in-network spending would incentivize expansion of planned networks, which is also consistent with the goals of SB 855 and SB 221. Improved access to community-based and outpatient care can also mean more culturally responsive care. Anecdotal reports from stakeholders suggest this is needed, as does survey data that report only a third of Latino, Asian, Native Hawaiian, and Pacific Islander Californians agree that their communities have mental health workers who have knowledge about their needs. Next slide. So it's important that OCA's approach to measurement and benchmarking aligns with or complements other behavioral health policies in California. These next few slides will review some of the important recent policies, and of course there are others we're not including here. But with the benchmark straw model in mind, we'll look at a few of the major policies, starting with Proposition 1. So one part of Prop 1 is the Behavioral Health Services Act. This new law reforms the Mental Health Services Act of 2004 and realigns behavioral health funding by increasing access to community-based care, particularly for high-need populations, such as those experiencing houselessness or who are involved with the justice system. A benchmark focused on community-based services could incentivize payers to increase investment in such services where these individuals live. The second piece of Prop 1 is the Behavioral Health Infrastructure Bond Act, which authorizes $6.4 billion in bonds to finance behavioral health treatment beds, supportive housing, community sites, and housing for veterans with behavioral health needs. A benchmark focused on community-based care would complement Proposition 1 investments and incentivize investment to additional areas of need to support local behavioral health infrastructure. Next slide. So another important, relatively new behavioral health policy is SB 855, which was passed in 2020 and which addresses parity for behavioral health services. SB 855 requires insurers to cover medically necessary treatment for all mental health and substance use disorders. To align with this, OCA will use diagnosis codes to differentiate between mental health and substance use disorders for a broad set of behavioral health conditions and services. SB 855 also mandates coverage for out-of-network mental health and substance use disorder services when in-network access is not available within geographic and timely access standards. It prohibits plans from denying medically necessary services on the basis that they could or should be covered by a public entitlement program. Our focus for the benchmark on in-network care covered by commercial and Medicare Advantage plans aligns with the goals of these provisions. Next slide. So SB 221, which passed in 2021 and became effective in 2022, ensures that appointments with non-physician mental health and substance use disorder providers are subject to timely access requirements. The law requires that an enrollee undergoing a course of treatment for an ongoing mental health or substance use disorder condition can get a follow-up appointment within 10 business days. Additionally, if a plan operates in an area with a shortage of providers and is not able to meet the geographic and timely access standards with an in-network provider, the law requires the plan to arrange coverage outside its contracted network. And as I noted on the previous slide, this is also a provision of SB 855. So OCA has the opportunity to align with SB 221 by setting a benchmark focused on in-network outpatient and community-based services that would encourage increased investment in and access to those services, while SB 221 holds health plans accountable for non-compliance with their timely access requirements. And in addition to the focus benchmark, OCA could complement SB 221 with potential analyses using data from the Healthcare Payments Data Program that leverage OCA's behavioral health measurement definition. So for example, potential analyses could include looking at quality measures related to behavioral health care and follow-up, the number and distribution of providers and facilities billing for behavioral health services, and licensed providers who are in payer networks as a percentage of total licensed providers in California. Next slide. So OCA has been working since last July with the Investment and Payment Work Group to develop proposals for the behavioral health measurement definition and benchmark approach. Last month, we updated the advisory committee with the same information we're reviewing here today. And next, we'll share with you a summary of the recent feedback we've received from the board, as well as from the advisory committee and the work group. So in December, at the board meeting, we provided you all an overview of our progress to that point. We heard from you support for a focused benchmark approach and interest in shaping the benchmark to support statewide goals. Board members emphasized the importance of future incorporation of Medi-Cal measurement and of collaboration with other ongoing efforts, including those measuring out-of-plan spending. And board members also talked about aligning OCA's policies with other care transformation efforts in California, such as those we've just reviewed. Next slide. So in January, we presented an overview to the advisory committee, and we heard there support from several members for the proposed benchmark structure, while one member supported including inpatient spending in the benchmark to align with Proposition 1. We also heard interest in linking benchmark performance to outcomes and in measuring continuity of care to ensure that goals are being met. Advisory committee members gave mixed feedback on telehealth, both recognizing that telehealth is an important access point and also acknowledging that there are challenges to ensuring high quality and equitable access to telehealth. And additionally, committee members suggested excluding from the benchmark spending for artificial intelligence and specifically behavioral health chatbots. Next slide. So this slide summarizes some of the feedback we've heard from the work group so far. So we've heard strong work group support for the benchmark straw model overall, although a few members have raised questions or concerns that the straw model excludes inpatient, long-term care, and residential settings. There was appreciation for including behavioral health screenings and assessments in the measurement definition, regardless of diagnosis or outcome of those screenings. And then some members have asked how our measurement definitions align with parity law requirements. Next slide. And our last slide. So this is our tentative timeline for the behavioral health work. We're planning to meet with the work group monthly through July. This is extended by 2 months from a previous timeline to allow more time for the work group to develop its recommendations and for the advisory committee to have a chance to consider them at both their March and June meetings. So currently, the work group is focusing on providing input on OCA's definitions for claims-based and non-claims-based behavioral health spending, including considering refinements to our behavioral health and primary care module. So OCA plans to bring a recommended behavioral health investment benchmark to you for board approval in July. And we'll be giving you interim updates to gather feedback from you in April and June and from the advisory committee in March and June. And now we will open it up. Oh, Margaretta wants to say something.
Yeah. Oh, sorry. First, I just wanted to open it up to Dr. Pan to see if he had anything to add in terms of the advisory committee feedback that we summarized from the January meeting, and then open up to broader discussion. Thank you.
I think you captured it pretty well. I'm trying to recall because that we did talk about not of this specific stuff, but I think what you said is pretty reflective of what that was discussed at advisory committee, as I can recall from now a couple months ago.
Thank you.
Sandra, then Don.
Thank you. A lot of really good work here. Appreciate it. I think the board, maybe even me, in December mentioned the importance of incorporating Medi-Cal. And so I'm wondering what the time frame is for that, how we think about where that fits in the timeline, and what maybe some of those challenges might be, number one. And number two, given that we are now dealing in a Prop 1 environment where we're hopefully starting to actually build some badly needed psychiatric beds, I wonder what the thinking is around excluding inpatient psychiatric beds in the analysis.
Sure, so I can start. So for the Medi-Cal timing, I mean, we are aiming to incorporate Medi-Cal as soon as possible, and if possible, alongside commercial and Medicare Advantage, both data collection and spending measurement. We are actively meeting with DHCS and working with them to kind of understand all of the complexities and the data sources of behavioral health spending in Medi-Cal. So that is just taking some time for us to get, to understand everything that occurs in the Medi-Cal market and to think about how we would capture that spending. So we're hoping that we can move on the same timeline, but wanted to note just how challenging it is to understand the data and collect the data there. In terms of in our work group discussions, there has been a real emphasis on focusing on outpatient community-based behavioral health services, with the emphasis on lack of access, great, as we've discussed before, the out-of-pocket spending on outpatient behavioral health services. So, and based on the data that we've seen, that there's a lot of need for, appointments and access to outpatient behavioral health services, according to survey data. So that's really been the emphasis of our discussions and how we might use a focus benchmark to support greater access to those types of services. I think we do recognize, and we want to emphasize that, inpatient and residential settings for behavioral health services will always be needed and are an important part of the behavioral health system and network. But there's kind of an emphasis in our work group on supporting outpatient and community-based services and more upstream services.
Yeah, I mean, interestingly, nobody really wants to be in a bed, period. residential bed, psychiatric bed, hospital bed, a lot of costs associated with that. But I think what we're experiencing and I am completely supportive both of the data that's been collected on community-based programs and completely supportive of that, and the absolute paucity of psychiatric beds that we have in the state is very much manifest in what we see in people who are experiencing homelessness all across the state. And that is an enormous priority, I would argue, for just about every social service, DHCS, county, city effort. And so I would encourage a longer conversation about how we think about psychiatric beds within the continuum of care, even though the goal is, of course, to go upstream. Prop 1, if it's used appropriately, should get us more beds, which are very, very badly needed in the continuum. And so I would just urge us to give that additional thought.
Thank you very much, Dr. Hernandez. And I think, there's so many parallel efforts going on at Health and Human Services with the Behavioral Health Task Force, with implementation of Prop 1 and the Behavioral Health Services Act. So I think, we're trying to figure out what is OCA's specific piece as, of course, DHCS, and I'm pleased to say HCI is implementing the workforce components of the Behavioral Health Services Act, which is very much needed. So I don't think any of this should be interpreted that we disagree with your point about the need to have the inpatient services available, and we'll continue to work with DHCS.
Thanks. I was curious about the cause of some of these terrible numbers that are embedded in your benchmark model rationale. And I mean, I assume, and it sounds from your discussion with Sandra, that you're making the assumption that most of them are related to supply side challenges. But I also wonder about how many of them are stemming from payers or purchasers and their unwillingness to make the investment. I mean, we've seen these huge spikes in demand post-COVID for outpatient services, behavioral health services in particular, and you see a little bit of resistance on the payer side about leaning in here. I ask in part because I'm thinking about OCA's levers here to help with this challenge, and I think if that's part of what's going on, there may be better levers than if it's supply side. I mean, you have a whole nother side of HCI that doing nice work on supply side also. But it just, as we're thinking about it, I'm wondering about how we potentially narrow in on that piece.
So we are working on digging into that exact question. Some of the initial research we found, both from kind of some survey of behavioral health providers and more technical research, has shown that there's a lot of contributors to why behavioral health providers may not participate in a health plan network. And they're, ranging from the administrative complexity, the kind of oversight of their ability to provide the care that they think is needed to folks in terms of potentially visit limits or prior authorization requirements, the lack of payment that meets that is analogous to what they can receive from self-pay patients or self-pay clients. So there's a few of those pieces that we have researched, and behavioral health providers have reported as to why they do not participate or choose not to participate in provider networks. And there's some other technical things that we're diving into. And so we'd be happy to come back once we kind of dig through everything that we're finding and summarize that for the board.
Could I just follow up on that? Just on that very quickly, thank you for doing that. But one thing you might consider here, I think on the outpatient side, like it makes sense to set a benchmark on a per patient basis, but given those market dynamics where for many or most commercial payers, they're actually paying below 100% of Medicare rates. Some kind of benchmark, it might make sense to have some kind of benchmark on a per visit basis if we're trying to motivate payers to recruit more to their provider panels and persuade their provider panels to take more patients through insurance. That metric might help achieve or further that policy goal.
I apologize. I have to take care of some healthcare things for my family soon, so have to run. But first of all, I think the benchmark that you're proposing makes a lot of sense. But I also hope that whether we have a separate benchmark or we at least track the data on the inpatient, I think it's going to be very helpful. I don't think anything restricts us to having only one behavioral health benchmark, because I'm concerned on the inpatient side. I don't want, because it's so much more expensive, I don't want to overwhelm, you know, the spending on the community side, which then, of course, you know, it could, if it's all inpatient, and we just have one goal, then I'm afraid that you know, that basically one gets at the expense of the other, right? So I certainly support what you are proposing for the benchmark, but trying to think about ensuring we still at least collect the data on how much is the inpatient spend and so forth. That's not the only data we collect, and maybe that other data will allow us to think about if we need a separate benchmark or not on the, you know, inpatient, residential, and other side. That way you can separate the two a little bit, but also if that's necessary to sort of push more investment there beyond what the state's investing in. And I guess the other point, and I really appreciate you mentioning the sort of cultural effectiveness piece as well. So hopefully things like interpreting services, which of course in behavioral health is even more important. I mean, it's already pretty important in primary care, but is an expense that is incorporated into that community outreach, particularly for, you know, the API community, where many patients do not, they may speak some English, but in terms of providing, you know, healthcare services, behavioral health services, you want to try to do it more in language. Of course, the Latino population as well, a significant other immigrant populations. So hopefully that gets incorporated into, because that becomes an access issue. Thank you.
Just a few comments also, maybe a bit of a scattershot actually, but you know, I was thinking of what Sandra was saying about access to behavioral health services, and I appreciate that for large swaths of our population, there's just no access, and we're starting to put together a construct on behavioral health. But we're very, very far behind, I think, our traditional medical care construct. And maybe the problem in behavioral health is still not spending too much, but spending too little. And we're just starting to grapple with this. For example, a couple of areas, and I agree, homelessness is a major area of focus from, you know, my urban LA perspective. But there's another big area also, which is substance abuse. And do we have any relevant benchmarks that we want to use for looking at substance abuse treatment, availability, things like this? And when we look at outpatient care also, there's a sector that may be the only provider for many people, especially young people, and that might be school-based behavioral health services. I don't know how we can capture that, because it doesn't involve reimbursement, it doesn't involve health plans. But for many young people, it's the only services they receive. Just some thoughts on this topic, because it's such a broad one.
Thank you for those. And I want to just add on a little bit there too. I mean, I think in this space, to the comments of my colleagues here, we are transforming behavioral health in California. So prior to the passage of Prop 1 last year, we had $10 billion of new investment in behavioral health in California. So you add at least 6 for the bricks and mortar actual facilities within Proposition 1, but then there's other components, and we've added since then with Workforce and BH Connect and some of the other efforts that we're making. So, and there are very specific, both kind of for the continuum, preventative and early intervention components, but also a lot of focus, focus on those with severe mental illness. And substance use disorder and others are also incorporated into some of these efforts. To the comment David just made related to schools, right? We are also right now in real time putting together the fee schedule in schools to be able to support them in their ability to draw down Medicaid dollars to support some of the investments that were seeded through the Children and Youth Behavioral Health Initiative. So somehow, both in terms of our kind of point in time understanding of how we want to think about these benchmarks with that kind of foundational context of what we are trying to do more broadly across the state, I think we need to capture that for kind of beyond our time. We have initial work to do kind of out of the gate here as we're thinking about this. And I also support like really looking at kind of benchmarks, what do we need to do kind of in an interim, but also in terms of the long term, really try to figure out how to capture that contextual pieces, both on population specific, but other very targeted interventions that we are working on in real time across the state.
Thank you very much, Secretary, and thank you, Dr. Carlisle. So just to be clear, we are including substance use disorder services in behavioral health, and it's critical, and thank you for keeping us honest on that. And actually, school-based services, as the Secretary noted, under the Children and Youth Behavioral Health Initiative, the wellness coach, the certified wellness coaches that I've talked about a few times, and we now have over 1,200 certified wellness coaches that are working in schools, and there's a state plan amendment pending with the feds to have them be a Medi-Cal provider, and under the fee schedule for them to be covered for kids both with commercial coverage and Medi-Cal, because we shouldn't be, how can schools sort that through? So yeah, really important points, and we're looking forward to incorporating that, and as we contribute to behavioral health transformation.
Thank you for the presentation. Adding on to Ian's comment, I do think it would be very useful to provide information about payment rates, which we ought to be able to do from the HPD, assuming there's something really in the HPD. That to provide information about payment rates for a variety of commercial insurers compared to Medicare, compared to Medi-Cal. Then what's not in the HBD but would be important would be compared to self-pay, which may be some survey supported by a foundation of providers, or maybe as part of licensure, gathering information from folks getting licensed about what their average, per visit payment is, and also as part of licensure to understand, what the payer mix looks like. And some folks are not doing any business with insurers, and some are half-half, and I can imagine that it'll be difficult to get high response rates and accurate information. But the out-of-pocket, out-of-plan we've talked about here many times. I don't think we yet have a plan to deal with that, and it just more exhortation there. A question, and Debbie, you mentioned excluding pharmaceutical costs, but then kind of coming back to a discussion of that. But I wonder if you could help us understand the flavor of those discussions, please.
Sure. So for pharmaceutical spend in primary care, we do not include it because it's sort of not part of the core things that primary care providers do uniquely. And so we're taking a similar proposal right now in terms of our initial discussions with the work group for behavioral health. We also are aware that pharmaceutical spend is a pretty large percentage of overall behavioral health spend. So if we included that, it might kind of overshadow any changes in the parts that we really want to focus on, which is the clinical care, and is less often the barrier to access. Like, people have easier time, it seems, getting medications than getting, say, psychotherapy. So that's our initial thinking.
Yeah, I guess my suggestion would be similar to the discussion about inpatient, that whether or not it's included in the main benchmark, it's certainly something that we ought to be keeping track of, as part of your larger measurement circle, but being aware of that as a category.
Yeah, we are planning to include it in overall measurement. We have drug codes in our code set for behavioral health measurement. So we can clarify that in the future in the slides to make sure. But yes, we are planning to include pharmaceutical expenses in the measurement of behavioral health spend overall, just not in the benchmark, at least as of our current proposal.
And then finally, just to make sure I understand, telehealth services would be included in the benchmark measurement, is that correct?
When they're delivered by providers that are kind of traditional providers, that's our plan to include them. We're having a lot of conversations about some of these, kind of platforms that employers may fund separately from health plans and things, but things that are paid through claims. The current plan is to include telehealth claims that are delivered in a similar way to in-person care.
Yeah, and just real quick, I forgot to mention this, but along the lines that that Rick just mentioned, I'd probably put a pin in the chatbot concept because it's probably going to come back to us. I think there are populations, communities, languages that artificial intelligence can facilitate discussions in. And I think as it gets better, I think some people will use that instead of more traditional providers because it may be more neutral in many ways, less challenging for them, and improve access as well. I don't know if this is at all state of the art. I doubt it, but 5-10 years from now, it may be a major component of behavioral health therapy.
Rick, I just want to clarify, I think I said this in January, so I didn't include it in my executive updates, even though the team included it for me. We are going to have a presentation about the healthcare payments data program for you all next month in March. So we look forward to presenting some of the public data and answering your questions.
I'll just do a plug. We had the benefit at CHCAF of having a little show and tell of the HPD, and it's quite impressive, and people are using the data, and there is data in there, so yay.
Billions of claims, in fact. I can't tell you how many billions, but a lot.
Great, thank you for that robust discussion. We will open up for public comment.
We'll now take public comment on this item, and as this is the last item of the day, we can move to general public comment also. We do have one hand raised virtually, so we will start there with Bianca. Bianca, you're unmuted on our end. You might need to unmute on yours.
Reminder, you think a couple years into this, I get this right. Bianca Blanco, California Director for Small Business Majority. I appreciate you taking my comment today and appreciate the robust discussion that's happening there. We are a national nonprofit organization advocating for very small business owners and their ability to provide quality jobs to themselves and their employees. I'm urging the board to act and not delay in adopting the sectoral targets, which will address the rising costs of healthcare for more than 4 million small business owners. Those small business owners make up 99% of total businesses in California. Small business owners, as well as their employees, make up half of all ACA enrollees in the country. So we appreciate the opportunity to speak to you about how the rising costs of healthcare are impacting our state's most prolific job creators. More than 1 in 3 small business owners report it's been a challenge to obtain health insurance coverage for themselves and their employees in recent years. 16% have reported that they've considered reducing healthcare coverage in order to keep their businesses open and their employees employed. Entrepreneurs of color, alarmingly, are more likely to indicate making this change. Let's just be honest. Small business owners simply can't afford Facebook-level benefits. The decisions that you all make today and in subsequent meetings will have sweeping impacts on the ability of Californians to start, run, and grow a business in this great state. We urge the board to implement any delays in slowing healthcare costs in California. Take swift action to reduce these costs today by adopting the targets and moving forward with the urgent reforms. Thank you so much.
Thank you. Going to the podium.
Beth Capel with Health Access California. Thank you for the board discussion on the more global policy changes that are underway on behavioral health. That's an important part of the framework of what's being worked on in the behavioral health benchmark work. And I think moving us to a world where people obtain the appropriate level of care, and whether that's upstream in a preventive way or in a hospital emergency room if that's what they really need. We also commend to the staff the board discussion about monitoring separately other spending such as pharmaceutical and inpatient care. We have supported generally the benchmark straw model as moving us in a good direction towards in-network care with less out-of-pocket spending and more upstream care. In the work group discussions, there's much focus on the experience of current providers without necessarily that broader understanding of the transformative discussion that the board just had. So the board's work very much complements the discussions in the work group. Thank you.
Thank you. Give it a moment. Seeing no one at the podium and seeing no hands raised, noting for the record, we have about 76 virtual attendees at this point. That should conclude public comment, both general and on that agenda item.
Thank you very much. And thank you for, again, a very robust meeting. And again, thank the staff for all of the preparation and for all of the public for joining us both virtually and in the room. We will see you again in March and at the new location then. So with that, meeting adjourned. Thank you so much.